for over 30 years. I feel so old when I say that. And I
But you
have
look so young.
What's that?
I said, but you look so young.
I still can't hear you, Jessica.
Oh, geez.
Now I can hear you. Just speak up.
I said, you look so young.
Thank you. I will take it.
Compliment.
Anyway, so yeah, I've been a nurse for 30 years and I've worked in just about every area of nursing except for a few, just a couple. I have done long-term care. I've done forensic psych, inpatient dual diagnosis psych, inpatient child adolescent psych, critical care, neurotrauma ICU. I've done medical ICU. I did an electronic ICU, which is a little different. It's telehealth. And so that was overseeing every ICU within a certain system. So I learned a lot because I had to understand and know patients that were post open heart. I had to understand and know patients that were post surgery, that were neuro, which I did know. But any critical care patient you could think of, we had to understand and know how those patients needed to be treated. So I learned a lot in that job. I did neuro research, neurointerventional research, which was really cool. I've done telehealth in a variety of settings, home health, like I said, critical care, and then I have done it as an admissions and education nurse, so patient education. And then, like I said, I have my master's in nursing, and it was an education focused master's. And so I've been teaching off and on, mainly on, but for the last 10 years. So I like teaching, I love teaching, and I love critical care. It is one of my favorite. Oh, I forgot ER. I spent a lot of years in ER. I'm like, wait, I forgot something. I did ER for a lot of years too, and I did travel as an ER ICU nurse. So, like I said, a lot. I don't do OB though. I don't do babies. I cannot help anything to do with OB. Nope. People go, well, you had kids. Yes, I had kids. My youngest is going to be 36. So I don't do OB.
Having kids and teaching peds and OB is two completely different things in my book.
Thank you. Yep, I agree.
If you all can't tell, Ms. Bresman is extremely qualified, way more qualified than me. And we are going to be working closely for this course, and I'm really excited about it. Me and Brandy have gotten along so well, just like right from the beginning, as soon as we met each other. And it's always nice to work with someone that you get along with really well and you can speak with freely and make decisions really well together. We have a very similar teaching style. So I'm really excited about that. I have absolutely no worries whatsoever about sharing with her. Oh, good morning, ma'am. Don't worry. You okay? Yeah. All right. So first things first, let's go over the syllabus. Is everybody in Brightspace? I had one friend that wasn't in. So is anybody having issues, excuse me, getting into Brightspace? And
it won't let me take the one like test to get for everything, but I'm just gonna try on a different computer later.
Okay. The little acknowledgement thingies?
Yeah, it like won't let me type in the one box, but I'm gonna try on another computer later, and if it doesn't work, I'll let you know.
Okay. Is anybody else having any issues? Brightspace. Okay. All right. Yeah, make sure you do your little acknowledgements, because if you don't, then you can't get access to everything. Okay, so this is RN2852, care of patients with complex health needs, number 2, numero dos. We have 35 lecture hours and 45 combined lab and clinical hours. So this is a total of 80 total contact hours. We're using the same book, the Honan book, and then we're also using the ATI Med Surg book. Your proctor, your ATI proctor is on the ATI Med Surg proctor, so that medical surgical book. Yay! It's the biggest one. So exciting. So we are going to be doing an emphasis will be placed on content related to care and needs of clients experiencing problems of tissue perfusion, regulation, metabolism, excretion, reproduction, concepts of emergency care and disaster preparedness. So this first week, we're going to do all cardiac EKGs. The people that were asking for, what do we do over break? I want to look at stuff over break. I hope that you actually did. If you didn't, it's okay. If you did, how cool and exciting. And I hope that it helps us out. And if you didn't, that's also okay. So we're going to go over a lot of cardiac. We're going to go over respiratory, ventilation, and tissue perfusion, and disaster planning, burns, shock, different types of shock. So as per usual, the week 2 and week 3 exams are 50% of your grade. The final exam is 30%. You have your Lippincott. There are 2 VSIMs that are assignments. Sorry, my brain is having a really hard time catching up right now.
I was gonna say, there's nothing week 4.
There is nothing in week 4.
So we don't.
Did I say week 4?
I'm looking because I write down my assignments so that I can do them ahead of time.
Yeah, I'm going to go over the course overview after the syllabus.
No assignment.
There is nothing in week 4. Week 4 is all, we'll get there. We'll get there. So there are 2 VSIMs, Vincent Brody and Carl Shapiro. I feel like we did Carl Shapiro.
I know, it looks so familiar.
Right? I feel like we already did him.
I think I did Carl for a lab makeup.
Okay, so we'll look at
I
that.
just wanted to say, I see Vincent Brody and what is that, week 2?
Yeah,
But I don't have another VSIM.
it should be in week. Will you just wait a
Well, I'm just
second?
saying, because you're saying that we got it, and I'm like.
I'm just looking at the syllabus right here. You just wait a second, 1 second, girl.
Because while
I'm
you're
gonna get
looking
there.
at it, I'm looking at stuff, and I was like, I don't have one.
So then we have the ATI video case studies. That's worth 5%. There's 1, 2, 3, 4 of those. And then, of course, you have your online practice, MedSurg Proctor A, B, and then the final Proctor. Remember, please upload your stuff to Brightspace, okay? If I don't have it uploaded into Brightspace, I don't see it, I'm not grading it. I'm not going into these things every day to look and see if you've done your work, okay? So please upload your report to Brightspace, all right? Just like last term. I don't know which one it is. I don't know if it's ATI or Lippincott that it says that it goes into Brightspace. That is
ATI.
false. That is so, I don't know. I need to get that out of there, remove that
'Cause that
from
was
the
me.
content.
Yeah.
Because nothing transfers automatically to Brightspace. Okay, which is I wish it did. I really do. I promise I wish it did. So the proctor, remember the grading for the proctor changed last term and it was nice. It was helpful that we weren't like freaking out about grades and the grade for the proctor didn't like plummet us down, right? So it's the same thing this month. The proctor practice A and B is a complete incomplete. So once you complete it with your remediation, you get a complete. And then when you take the proctor, a level 3 is 100 points, a level 2 is 85 points, level 1 is 70 points, and then below a level 1 would be 55. And you have to do your remediation with it to get those points. Okay. We all know we have to get a 76% to pass our courses. And that's that. So let's go over our course overview. So, do you want me to pull it up or is everybody looking at it?
I'm looking at mine.
Okay. If you want
I'm
me to
looking
pull
at
it up.
mine as well.
If you
Okay, cool.
wouldn't mind pulling mines up, because I don't have a class in Brightspace. I know they're probably still working on my stuff.
Okay.
I
Rashonda,
think I
did
have it
you?
in my email though.
Yes, I was just gonna say it is in your email. That first email that I sent out, it's at the bottom of it.
Okay. Okay, I see it here.
Okay, so week 1 is gonna be all cardiac, and all of your assignments are due on the 11th, which is the Sunday, right? I wrote those down before I came in here. Yeah, that's Sunday. January 11th, you have the cardiac arrhythmia worksheet. So I don't know if you'll be able to get through that entire worksheet because we still have it depends on how much we get through this week of that EKG paper or PowerPoint for the arrhythmia paper. So if you can't get through all of it, that's okay. And we're going to get through that together. All right. So that arrhythmia worksheet, I'm not going to hold you to like a really strict deadline because EKGs are notorious for it's hard for people to like really wrap their heads around. We are going to work on this stuff together. Okay. And then you have an ATI video case study, perfusion and perfusion cardiac. Next, oh, I'm sorry, cardiac catheterization with stent. Then after that is the Carl Shapiro, and then also is your practice A, med surge A.
I don't have that. Says that with my assignments.
I literally printed this from Brightspace.
Yeah, I have cardiac EKG worksheet, ATI, the video case study, diffusion cardiac, ATI medical surgical practice aid with remediation. That's literally all I have for assignments. EKG.
I just printed this morning. How is it different than the one that you're? I don't know.
No, I got the same.
Is that the one from the email, or is that the one on Brightspace?
Yeah.
I literally. Oh, you're looking at the assignments. I need to fix that.
Yeah.
I need to fix that. I'm looking at the overview. I'm gonna fix that today.
Okay, where do I find the overview?
Girlfriend, I gave it to you in the email,
And it's under welcome.
and it's under welcome.
Oh, well, we'll go to welcome. Probably, I got it. Yeah.
You did because you responded back to me that you wanted a copy.
Well, that's probably the only thing that I've seen.
Well, at least she's on it. She said that's the only thing I saw.
Overview now.
It's on the first page. Go to the right.
Yeah, it's all the way to the right under assignments. Everybody sees what I'm looking at, yes? Okay. See, I should have just, I'm gonna pull it up. I already upset Lisa on day 1.
I just have to rewrite because I try to go and do my stuff early. And I was like, well, this is not a whole lot to do.
So there's 4 assignments this week then.
I'm just gonna pull it and share it.
Yeah.
That would be easier.
It's just, yeah.
And this is why we do this. Okay, can everybody see my screen?
Yes.
All right, so week 1, this is what I'm talking about right here. We have our cardiac arrhythmia worksheet. Like I said, we're going to do that together. We have our ATI video case study, perfusion cardiac catheterization. Excuse me. Next, we have the Carl Shapiro Lippincott. And then your practice A with remediation. Okay, so that's week 1. That is due on the 11th. Okay, so then week 2, we have our exam, our math exam, per usual. And then for assignments, we have an ATI video case study, gas exchange, oxygenation, and oxygen delivery systems. So that these are all due on the 18th, January 18th. Then you have your next VSIM, that Vincent Brody. And then the ATI Med Surg Practice B. Okay, that is all on the 18th. And then after that is the 25th. So week 3, due on the 25th, is going to be your burn worksheet, the ATI video case study, critical thinking, critical reasoning, clinical judgment, rapid response, and clinical emergencies. Mouthful. There's another one that looks just like it, but it's different at the end. It says mass casualty triage and disaster management. Okay, so it's not repeated. There's 2 of them and they have different case studies. Okay. Week 4 on our schedule, the 26th is a Monday. Okay. We have class from 8:30 to 11:30. That is review. That is going to be a whole review. Okay. After that is our proctor from 12:30 to 2:30. So we have review from 8:30 to 11:30. It is part of our lecture hours, so you have to be here. And then the ATI Med Surg Proctor is on Monday, the 26th, right after our review from 12:30 to 2:30. Okay. January 27th, Niles and North Canton are all coming to this campus, the North Canton campus. Okay. I need to make sure all of my Niles people are hearing me. You hear me? You're coming to my campus, North Canton campus. Okay. And we have a lab from 8 to 4. This is mandatory and counts towards your clinical hours. Okay. And it's a very fun day. It's very, I promise you, it will be a very fun day. On the 28th, Elyria and Sylvania, we are doing a lab at the Elyria campus. Okay, from 8 to 4. It is the same lab, just at another campus. Okay. And then Dayton, I don't have any Cincinnati people, right? I only have Dayton. 2, right? My 2 people from Dayton, is that right? I think that's right. I wish, it's gonna be so silly. I wish you guys could come up to a different campus. Because it's not gonna be fun with just the 2 of you. I mean, I guess you could do it against each other, but that's gonna be a long day with just the 2 of you. Let me know, Chantel and Amara, let me know if you guys would be willing to travel to another campus. I know it would be a really far drive. If not, believe me, we will make it work. If you're willing, I think that would be really cool, especially to be able to be with other classmates to experience this. If you're not, obviously that's okay. It's a long drive and I don't expect you to make that drive if you can't do it. Okay, so let me know. Consider it, think about it, and let me know. And then on the 30th is our final from 1 to 3 p.m. Okay. Any questions about assignments, due dates, where you are supposed to be, especially that last week. Very good. Okay. Okay. And Rashonda, I need you to remind me later. I need to figure out if you're going to be in group A or group B. I know, Nicole. She said, I always feel so overwhelmed on day one. I know it's a lot. But I want to make sure that we go over all of our schedules and everything so that we know exactly where we're going to be. There's no confusion for anyone on where you're supposed to be at what day and what time. Okay. Rashonda, remind me. Oh, you changed your last name.
Yes, well, I did it before, but it just
Mrs.
like
West.
registered, yeah, in the system.
She's Mrs. West now.
Yes.
So remind me, I need to figure out if you're going to be in group A or group B for North Canton.
Okay.
Because I had to split you up because you guys are doing a rotation in the ICU and you're also doing a rotation in step down at UH Ravenna.
Oh,
Portage.
nice.
UH Portage. So don't let me forget that. Okay, any questions? How are we all doing? Very good. Questions online?
I have
Okay.
a question, but it can wait until after. Is this
Go
regarding
ahead.
ATI? I don't have access.
Oh, okay. Send me an email, Miss Annalisa.
Okay.
So that we
I
can
sent
get
you
that
one.
figured out. CC Dr. Bowling, because she's our
Oh,
ATI champion.
okay.
Speaking of that, I actually have already taken that, I think that med surge thing.
The proctored ATI. How would you have taken it?
So when I first started, we were told like we were allowed to go through the ATI and jump around. So I think I already have it done.
You
I'll
mean the
double
practice
check.
test?
No, it was I'm pretty sure it was the proctor, but I'll look to make sure, but I think I've already done it.
Well,
And I
you
don't know
can't take
how or why.
You're in med surge too.
that's impossible. You can't take the proctor without a proctor. You can take the practice if it's enabled, but you can't take a proctored test without someone proctoring you and like allowing you into the test.
It shows up on my ATI as a proctored exam. But my memory is about this big, so I couldn't remember when or how or why I took it.
I feel like we took it during med surge. To be like quite honest, I do think that we did that.
Well, I mean, if you did, you did. That's okay. That's just going to help you out in the end. You know,
Oh, I didn't know if I needed to like retake it or what.
you
Or if it could
absolutely
be
have to
white.
take it.
Okay, so it'll be like it won't have to be a problem when I go to take it then.
Correct. And you know what, Annalisa, and it's probably the same for Rashonda too. We have to add you to the cohort. We have to change your cohort, and that's probably why it's not in there for ATI. Yeah.
Right.
So still send that email. Rashonda, you sent an email too about your ATI.
Okay.
Is Mayana in here?
Okay.
Ayana,
Last
are you here?
question.
I'm here. It'll probably be the same for me as well.
Yes, please. Thank you, ma'am. Go ahead, Annalisa.
So the VSIMs, I've taken all of I've done those. So you want me to redo those?
So for those, when you get your new book code, Justin at Lippincott will scrub your Lippincott course. So you will be able
Okay.
to redo those. Yes, ma'am.
Okay. Thank you.
And same for Rashonda and Mayana. Okay. All right. Any other questions before we get started? Actually, let me just take a quick attendance and make sure I have everybody here on my roster. So I already saw Chantel, Amara. Where are you at, girl? Oh, I see you.
I'm here.
Shalaya, Miss Shalaya Jackson. Where you at, girl? There you are. I see you. Santera Jones, I see you. Sharia, I already saw you, girl. Rebecca Ortez, I already let you in. Tiffany, I see you. Kelsey, I think I already saw you. Yep. Emma Webb. There you are. Joanna Wilson, there you are. Mariah, Jackie, Tonasia, Ginger, Rodnea. She's not here. Sarah, Whitney, I already saw you. Alyssa. Miss Alyssa G, there you are. Amy, if there you are. Nicole, I let you in. Brianna Hodges, yes. Kristen Kane, I saw you. Amy, I saw you. Kaylee, I saw you. Tiana, I saw you. Kiara, Latasha, Adrian, Chelsea, and Lisa. Okay. Beauteous. All right, are we ready? Let's do it. What?
30. I believe we'll early last night.
Okay. What time are we scheduled till today?
3:30.
3:30?
Yeah. The whole. Yeah, for the whole month.
Like,
Yeah, I thought yeah, we're scheduled from 9:30 to 3:30.
wow. That's gonna be a long day. Wow. All right, so this is what I'm gonna ask of you, especially my online people. I mean, you guys here, we can get up, we can stretch, we can walk around. I can see it on your faces when I'm really losing you. But online, if you are feeling like I literally cannot understand a word you're saying right now because my brain is gone, I need you to tell me, hey Jess, I need a break because I'm not retaining anything and I cannot even right now. Okay, can you do that for me? Okay, good. Do you want to do math now or later?
Later.
We have to do it.
Let's do it later.
Let's just do it now.
I feel like if we do it now and get it out of the way, it's probably better.
I think we should like get it out of the way
Yeah.
Get it out of the way.
Yeah.
before we jump into this heavy load stuff.
So we do, it is going to be exactly the same math, but it is not, we do not have a module, right? There is no ATI module. So the math is literally exactly the same as what we did last month, but I need your success because it's good for me and my soul and for you.
She said my soul.
So I would like us to just go through our math, make sure we're all feeling good about it, so that then we can all pass our math on the first try.
So this will be our testing here?
Huh?
So it's gonna be like our,
Ticket to test?
yeah.
I think there's a worksheet in Brightspace.
Yeah.
Yeah, there's a practice in week 1, right? Hold on. Okay.
It's under a math tab, so it'll be separate.
Yeah, it's
Yeah.
not gonna be under,
It'll be on its own tab.
hold on. Oh, that's dumb. Where is math? Oh, see, that's kind of silly. Okay, so that's different. Good point. Thank you for pointing that out because that's different than it's ever been. So everybody in your Brightspace, the math worksheet for week 1 and the math remediation 1 and remediation 2, which you're not going to have to take because you're all going to pass the first time, are all under, what's it called? Ticket to math tests under the math requirement tab. So it used to be in the weeks. Now it's under the math requirement tab. Does everybody see that? The chat. Now, later, now, later, now, later. Are we door dashing?
We got my grade on.
Could we see what the practice for now?
Oh. You mean like,
You want them to do within 24 hours or?
Adrian's asking about clinical packets. You guys all know I am not the one that's gonna be like, gimme, where's your clinical packet? I need it right now. I need it within 24 hours. I need it right now. But the thing that is gonna be really helpful this term is that I have Mrs. Bresman helping me. So she's gonna be helping me a lot with grading, making sure that everything's turned in on time and stuff like that. And you know, we, like I said, have very similar teaching styles. We prefer that you guys are understanding your content, taking advantage of your clinical experience, and you know, understanding everything and making the best out of it, than you running around trying to get a clinical packet done within 24 hours. Okay. Do you have to turn in your clinical packet to your clinical instructor for feedback?
No.
Yes. Yes.
Wait, turn it in.
What do you mean?
Not turn it, like you need to go to your clinical I do not grade clinical packets.
I'm hard
Okay.
confused.
Well, didn't you help them out whenever?
They sign off on it? Is that what you mean?
Right. When you
Yeah.
talk about your patients, which Maria should be
Yeah, we do, yeah.
looking at your packet, putting her little whatever on it, and giving you feedback on your SBAR, on your clinical packet, right?
Oh.
This should be happening.
I was confused on the way you said.
I want you all to say yes, she does.
I was confused on the way you said it.
What she definitely talks about, you know, like,
Good.
And
Good.
you said.
So I said that because there are some clinical instructors like June Brock. She has you email them to her so she can give feedback. You guys are gonna have Shauna Pulvery, and God, I love that girl. I worked with her in the ICU, and she is the nurse practitioner in the ICU at UH Portage every other week on midnights. So she knows that ICU like the back of her hand, and she's gonna be teaching a couple of your clinicals, and I'm so excited. What? So I don't know. It really depends on the clinical instructor and how they want to do that. But they absolutely should be giving you feedback on your clinical packets. Good.
Yeah, she's pretty thorough when I see all.
Right.
The night at the round table, like everybody.
Good. I
Yeah.
love it. And throughout the day, right? Then, which is how it should be done. So like I said before, I want you putting your clinical experience first. Clinical is what you make it. Okay. I do not want you sitting in a back room writing down clinical packets for hours instead of going and having patient care experiences. Okay. This is what it's all about. So, I believe on the paper, it says 7 days, doesn't it? Doesn't it say a week on the clinical packet?
I think it's always.
But then in the clinical expectation sheet, it says 24 hours. Okay. So, the majority of you guys have clinical on Thursday, Friday. So how do you feel about your clinical packets being due? Now you tell me, Sunday night or I mean, Sunday would be easy because everything else is due on Sunday, right? Doesn't that sound, I mean, it's like in between. How do we feel about that? Sundays?
I have a quick question.
Yeah.
Did we already do the clinical contract? Did you send that already for this month?
No, ma'am. I'm gonna work on that today and tomorrow, sending those out DocuSign.
Okay, 'cause I think we have clinical tomorrow.
Okay. Do not fill one out at clinical. Okay. Wait till you get mine.
Okay.
Okay. Thank you for asking that. And I'll try to get yours sent out today.
I know you
Maybe-
had said Sunday night. Is there any way we could make that like Monday night? Only asking because I don't know about everybody else, but I work every single weekend and it's kind of crappy. So I don't have time to review it throughout the weekend. But Monday after class, I could do that.
I was going to suggest Monday night, but I didn't want to confuse anybody and be like, wait, when is that due? When is this due? When is that due? Because I really was gonna say Sunday or Monday. So if you guys are not gonna get confused by me saying Monday, I'm perfectly fine with Monday.
I too work every weekend.
I used to work every weekend during nursing school too. It was horrible. It was literally the worst.
The only weekend I'm not working the full weekend is this coming weekend because Saturday is my wedding anniversary. So,
Oh, happy anniversary.
thank you.
Welcome. Okay. Well, I feel like now we need a break because it's already 10:15.
I completely agree.
All right, let's go take a couple minutes. I'm gonna go get the thingy for the math, and get that over with so we can get into this. This is gonna be a long day. Get your coffee made, order your DoorDash, and we will be back in 10 minutes. We ready? I sent you a math worksheet in your email.
Does anybody have a pencil? I cleared out my bag and then I went back.
Oh, one of those extras were mine. Lisa said I didn't want it anyways.
My calculator, pencils.
Oh boy, this is gonna be a long day. Long, long day. Kira, you're gonna have to, the easiest way is to find somebody to switch with you. Because I haven't put her in a group yet, so if it works with her, then that would be your. Okay. Where is everyone? Why are they not back? Oh, I would have done it for them. Okay. All right. Well, let's do some math. Unfortunately. No, I love math. Everybody see I sent you a worksheet in your email?
Yeah.
Okay. All right. See my paper?
Kinda.
What do you mean, kinda?
I don't know how to make you bigger on my screen. Does anybody know how to do that so I can see it? It
There's
doesn't
a
matter. Just
Zoom
keep going.
option. No, there's a Zoom option. Can you close the door, please?
Okay, thanks.
All right. So a patient is going home on Benadryl syrup, 65 milligrams PO daily. Available is 10 milligrams per ml. The nurse should instruct the client to take how many teaspoons daily?
I got 6.5. Is that not right?
That is not correct.
Okay, so what did I do wrong? Let me work it out. I'll see y'all back.
So how many mLs is 1 teaspoon?
5.
5 mLs and 1 teaspoon.
Mhm. So I'm looking for mLs. So I have 1 ml is equal to 10 milligrams. My order is 65 milligrams. Equals 6.5, but then I need to, so that's 6.5 mLs, but I need teaspoons. So how many teaspoons? So if there's 5 teaspoons, or I'm sorry, 5 mLs in each teaspoon, we need to do 6.5 divided by 5. Divided by 5, which equals 1.3 teaspoons. Did everybody get that? If you did not get that, do you see
Yeah.
how we ended up there?
Do now. Stop.
Yep. And this is why we do this. Next one is easy peasy. We're just converting pounds to kilograms, right? So
Mm-hmm.
224 pounds divided by 2.2 is 100.4545. Our directions say, please round to the nearest tenth, which is going to give us 100.5.
100.5.
Okay. Everybody got that answer?
Mm-hmm.
All right, so next. A provider prescribes Epotin Alpha 140 units per kilogram subcutaneously 3 times a week. The client weighs 133 pounds. Available is 10,000 units per ml. How many mLs should the nurse administer per dose? So available, I have 10,000 units per ml. My order is for 140 units per kilogram. Now, if you remember, which you probably don't, that's okay. I like to do my conversion first. So I'm going to convert my pounds to kilograms first. So 133 pounds is equal to, of course, they're not going to make it easy. So remember, what not do in the middle of a question. We do not round in the middle of a question. Okay. So this is not giving me a nice, beautiful answer. It's giving me 60.45454545, blah, 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 continuing. Okay. So if you round in the middle of a question, it could change your answer, right? So we're not going to do that. So we are looking for mLs. I have available 1 milliliter is equal to 10,000 units times 140 units per 1 kilogram times we have, let's do the conversion in here. So 1 kilogram is equal to 2.2 pounds.
1.2.
Wait, no, I did that wrong. Crap, hold on. I hate doing stupid conversion in my math problem. Okay, hold on. I don't want to do it right or do it wrong and confuse you. I have ml over 1 equals 1 ml per 10,000 units times 140 units per 1 kilogram times yeah, 1 kilogram equals 2.2 pounds. Yes? Yes, thank you. Okay. My brain was on break too, okay? 1 kilogram is equal to 2.2 pounds times 133 pounds. There we go. Pounds, units, and what I left with is mLs. Am I forgetting anything in my problem? I don't think so. All right, so we got 140 times 133 equals 18,620. And we have 22,000. So 18,620 divided by 22,000 equals 0.84636. Continuing. And what are our rounding rules? Oh, you guys couldn't even see what I was doing. So our answer is 0.8 mLs. Did everyone get that answer? If you did not, do you see how we ended up getting that answer?
Yes, I do now.
Okay. Do you want to go through it, Sharia? Are you okay? Good. How does everybody else feel about this problem? Good. Okay. I'd rather you speak up than not speak up. All right, so a nurse is preparing to administer vancomycin 1.25 grams every 12 hours IV. Your supply is shown. How many vials will the nurse need to administer? So what I have available is 500 milligrams per vial. Divide contents with 10 mLs of sterile water for injection. So that means it's going to be 500 milligrams per.
10 mLs, I think, unless it tells you different. It
No,
doesn't tell
I
you
think
it's more with dilution, because usually if it's more with dilution, it'll say it. It'll say like you'll end up with 10.2 mLs or whatever.
right. So 500 milligrams per 10 mLs. And then our order is for 1.25 grams. So how many we have to convert? Are we going to convert milligrams to grams or grams to milligrams? And does it even matter? You could go either way, I guess. Which way did you go, Lisa?
With milligrams.
You went to milligrams?
Yes.
So
150 is with 1.25 grams.
okay. And we're looking for vials. So there's 500 milligrams per vial. So really, it would just be 1250 divided by 500, which is what?
2.5.
Which is 2.5. So this is very much less dimensional analysis and just math, just regular math. Does everybody see how we got there? Go ahead.
Would you not say at that point, would you just put 2.5 vials or would you put 3 because you can't give half of a vial? So would
You can absolutely give half of a vial.
Yeah, you could discard the rest, but you would need 3 vials to give 2.5, right?
You're saying, would you have to pull 3 vials?
Would.
Yes, absolutely.
So the answer would be 3
No.
No, because you're only giving 2.5.
Okay, I was just
Right.
thinking
So we're talking about,
3, so.
she's asking you if you have 2.5, but you would have to pull 3 vials in order to get 2.5. So would the answer be 3? No, because we're asking what's being administered,
Okay. That
right?
makes more sense.
You can waste that other half.
Exactly. Good question. I don't want you putting 3
I would have thought.
because I understand where your brain went, and I'm glad you said it. Okay, so a nurse is preparing to administer 0.45% normal saline, 1000 mLs IV to infuse over 8 hours. The nurse should set the IV pump to deliver how many mLs per hour? This is as easy gets, right? ml over hour, and we have 1000 mLs over 8 hours. And that's all you need in your problem right there. So what is our answer? 125 mLs per hour. Did everybody get that? Look at you guys. We're just flying through this math. All right. A doctor prescribes amoxicillin 9 milligrams per kilogram to a child weighing 80 pounds. Amoxicillin is available as 40 milligrams per ml. How many mLs should the nurse administer? So, available, I have 40 milligrams per ml. Our order is 9 milligrams per kilogram, and our kid weighs 80 pounds. So is this going to be nice math where I can 80 divided by 2.2? No, of course not. The math committee wanted us to struggle. Just kidding. I'm on the math committee. Sorry. Okay. So we're looking for mLs. So 1 ml is equal to 40 milligrams times 9 milligrams, oops, per, ignore that, per 1 kilogram times 1 kilogram is equal to 2.2 pounds times 80 pounds, right? So I know I'm right because I can cross off pounds and pounds, kilogram, kilogram, milligram, milligram, and what I'm left with is mLs, which is what I'm looking for, right? So 9 times 80 is 720. 40 times 2.2 is 88. 720 divided by 88 is 8.181818, which is going to be equal to what? 8.2, because we are only rounding to the 10th. Did everybody get 8.2?
Yeah, 8. So I must have rounded.
Did you round your weight in the middle of the problem?
No. I'm gonna go back.
Okay. Did I miss a chat? For some, I can't have the chat open at the same time as sharing this screen. Oh, yes, I can. Did you see where?
Yeah, because it's 8. The 8 is in front of the 1. It should have been a 2, but I didn't round. Cause I got 8.1818181818.
Right.
Yeah, I just didn't round.
Oh, gotcha. Okay. She said I just didn't round. Okay. The patient is prescribed an oral elixir with the dosage of 4.2 milligrams per kilogram per day. The patient weighs 36 kilograms. Oh, that's nice. They converted for us. The label on the bottle reads 2.5 milligrams per ml. How many mLs of the drug should the patient be given in a single dose if it needs to be taken 2 times daily? So available, I have 2.5 milligrams per ml. You don't need to do this. I'm just doing it so, I don't know. I feel like it's better teaching. Milligrams per kilogram per day. Now, don't let this trick you because this says per day, and then it's asking you how much is given in a single dose if it needs to be taken 2 times daily. So that means it needs to, that final answer is going to be divided by 2, right? So don't fall for it. So I have 1 ml. That's equal to 2.5 milligrams times 4.2 milligrams per 1 kilogram. This patient is 36 kilograms per 1 day. Okay. Is that the air or is it heat?
It's definitely. There's reason.
We need to check all of our 151.2, 2.5. which is 60.48, but we're going to divide that by 2 because it's 2 doses, which is 30.24. Oop, I wrote 5. 30.24, but that's not the answer because we are rounding. So our answer would be 30.2. Do not forget to round, guys. In the instructions. Please make sure you read your instructions on each problem. Everybody get 30.2? Let me check this thermostat. Derek's gonna go check the thermostats and make sure that they're all turned the right way. I don't know what this star means. I don't know what that means. Okay, moving on. Number 8. A nurse is preparing to administer epinephrine 12 mics per minute by continuous IV infusion. Available is epi 1 milligram in D5W, 250 mLs. The nurse should set the IV pump to deliver how many mLs per hour? So I have available is 250 mLs per 1 milligram. So we have mics and milligrams. Are we converting to mics or are we converting to milligrams?
I
Okay,
converted
so
to mic.
Okay. So what was your conversion then? What was yours?
For milligrams, I got 0.012 for to convert like something. Do we have to do it?
So 12 mics equals what? 0. What?
0.012 milligrams.
Milligrams. Did anybody do it the other way?
Yeah.
Okay. All right. So you really can convert either way. It doesn't really matter because in the end, it's going to be the same answer. But it's just, do you want to deal with a lot of zeros and decimals? And either way, you're going to have a decimal. Either way, you're going to have zeros. It's pick your poison. Okay. So we have milliliters per hour. We have 250 milliliters per 1 milligram times 0.012 milligrams per 1 minute times 60 minutes is 1 hour. Okay, so I have minute crosses out minute, milligrams crosses out milligrams. What I have left is mLs over hours, which is what I was looking for. Okay, so we have 250 times 0.012 times 60, which equals 180 milliliters per hour. We didn't even have to divide it by anything because everything on the bottom was 1. Did everybody get 180 milliliters per hour?
Yes.
Did you do it with the opposite conversion? You did? Good.
I just worked it out like with breadcrumbs.
Which is fine, but I'm saying the opposite conversion as in 12 micrograms is equal, or I'm sorry,
Times 1,000.
1 milligram is equal to how many mics? 1,000 micrograms.
Yeah, that's
So
what I
you
did.
could have done 250 mLs is equal to 1,000 micrograms times 12 micrograms per 1 minute times 60 minutes over 1 hour. So that gives us 250 times 12 times 60, which is 180,000 divided by 1,000, which is going to give us 180. So you see how we did that both ways? So it didn't matter which way you converted. Okay. How we doing online, friends? You're not talking to me. I mean, you are talking to me a little bit, but just giving me answers.
That last one I did the second way that you did it.
And you ended up with the correct answer?
Yes, I did.
Perfect. Okay, so remember our two-parter question that we had last term? Well, here it is again, friends. She has arrived. Woohoo! Remember. Okay, that one.
Yeah, but you specifically said this question you can't do it. Wipe it out.
Because I couldn't remember which test it was on. She's saying, remember I told you you can't double the answer for the first part of the question because if you do, because of the rounding and everything, you will get the second half of it wrong. And I couldn't remember which question it was that applied to. I mean, it applies to this question. I couldn't remember which exam it applied to. All right, so a nurse is preparing to administer esmolol 30 mics per kilogram per minute by continuous IV infusion for a client who weighs 110 kilograms. Available is 2,500 milligrams in 250 mLs. And our order is for 30 micrograms per kilogram per minute. I'm looking for milliliters per hour. So, am I converting to milligrams or micrograms?
I did both.
So you did 30 mics to milligrams? Okay. Did anybody do it differently? No? Okay, so what is my conversion?
Well, this is after I converted everything. I do it differently than you see.
Well, still it's a conversion. So what is 30 mics? How many milligrams is 30 mics?
Okay, I converted it to micrograms. I got 0.3, but yeah, 0.03.
0.03?
Yeah.
So you did it milliliters per hour is 250 mLs. So how many, what did you do?
I did 30 times 110 and got that. Because it's per kilogram per minute.
Okay, so you skipped ahead.
Yeah.
I'm only talking about the conversion. So if you went the other way.
Yeah. Right before the last step.
I'm not talking to you about that right now.
Like you write it all the way out. Yeah.
30 mics equals 0.03 milligrams.
Yeah, I don't get that.
That's what I did. I just.
Okay, so we have 0.03 milligrams. Our order is for, see, you got me all screwed up. I'm doing it wrong. You got me all screwed up. So we have 250 mLs per 2,500 milligrams. times 0.03 milligrams per 1 kilogram times, what is this person? 110 kilograms? No, it's already converted to kilograms.
110 kilograms. Shit.
Yeah.
Ooh, I didn't pay attention to that.
Mm-hmm. Per minute. Times 60 minutes over 1 hour. Hi. What's up? Who? Oh, okay. She doesn't really have a voice. She's very sick. All right, so 250 times 0.03 times 110 times 60 is 49,500 divided by 2,500 equals 19.8.
Yeah, like you lost me for a second.
And that's what matters. So with this specific question, if we were to just times this by 2, it will equal 39.6. Now, the next part of the question, a provider increases the rate of esmolol to 60 mics per kilogram per minute. The nurse should set the IV pump to what? So instead of this 0.03, it would be 0.06. So 250 times 0.06 times 110 times 60 would be 99,000 divided by 2,500 equals 39.6.
And I found out how to tell if you could just double the time.
Well, I'm
I
so
did
glad.
something wrong.
The first answer comes out past something.
What did you do wrong?
I did the first part, I believe, right. 110 times 30, which gave me 3,300 for the weight.
Okay.
And then the 2,500 milligram and 250. I got 0.1.
Did you convert your milligrams to micrograms? Or I'm sorry, your micrograms to milligrams?
When I converted, I got 3.3.
You're gonna have to share your screen with us, my friend.
Do that. See.
Why isn't my computer charging?
She said she got 0.1.
Yeah.
I think she's doing it the way I'm doing it, and if she's gonna do it that way, she probably didn't do the 4,500 divided by 250. So you could make and she would divide 3.3 by 10 and then times it by 60 to get 19.
Oh my goodness. You're saying a lot of words there.
I had it wrong when I got there. We did it again. The right answer was
So I just tried to do it. I thought she did it and I got 0.12, but
Sharia, are you doing it again?
Yeah, I'm redoing it. Okay. 0.33.
How do you feel about the math, everybody? Everybody feels good? Okay, so we're all gonna pass the first time?
Yes.
Good. Because please, before your exam, just do this worksheet one more time. Okay? Don't look at the answers. Print it out, write it out, do whatever. Sit down for 20 minutes and just do this worksheet before your exam. Okay?
Okay, I got it. I had it backwards.
Worksheet that is in on Brightspace for week 1 is different than this. I didn't want to do that.
I just wanted to know.
Because I wanted to make sure that people still did the worksheet. Because I feel like if I would have done that way, then everybody would have been like, oh, this is the answer, you know, instead of actually doing it. So even though we did it together anyways. Okay, so that was a lot of math. It's 11 o'clock. We need to get into our content. Sharia, you said you ended up getting the right answer? Wonderful. I love doing this because multiple of us, especially that first question, sometimes we didn't see that it was asking for teaspoons, right? And then Ginger, that last one, you didn't see that it was already kilograms, right? So she was going to do it off 50 kilograms because she thought had to convert. So make sure you read your question, make sure you read your rounding rules, okay? And we are going to be completely prepared for our math exam. We are going to go to lunch at noon. We're going to do a half-hour lunch. We're going to try to get through as much of this PowerPoint as possible. But I got to pee first. So we're going to take a 5-minute pee break. 5 minutes, legit. And I'll be right back and we're going to get into cardiac. All right. Ready? He says,
No, you just leave me back there. Oh, well, somebody's face.
And just so. You're going to go down and not be able to say that either. It's just.
okay. All right. Cardiac.
Just a quick question. Are you going to share the link for the Notebook LM that you made?
So I was actually just thinking about that. Do I want to share it for the one that I made because it's not like great? But I was thinking about making a new one with this new content. Not new content. It's not new content, but my new PowerPoints and my new videos. That's what I was thinking. I feel like that would be better. I was literally just thinking about that. So the old one, no. I'm going to make a new one with today's lecture and then I'm going to keep adding to it. Does that sound good? Because I feel like that's going to be better than before.
That works because I do listen to like the podcast thing that you can create with it while I'm driving.
I know, they're cool. They're really cool. Okay, let's do it. All right, so we are going to do a cardiac overview. Function, coronary artery disease and atherosclerosis, heart failure, MIs, pulmonary edema, cardiac tamponade, hypertensive crisis, and vascular emergencies that include aneurysms. Okay, and I'm not talking brain aneurysms, I'm talking about aortic aneurysms. Okay, I just want to make sure I have my chat up. So we all know, at least I hope you know, that the cardiovascular system is a series of organs that work together to circulate the blood throughout the body. It includes the heart, of course, which pumps blood through blood vessels. There's 3 different systems to pump the blood. We have veins, arteries, and capillaries. Okay. We know that arteries carry our oxygen-rich blood. We know that veins carry the deoxygenated blood, and then capillaries are the tiny vessels that allow nutrients and oxygen from the blood to diffuse into the surrounding tissues. So we have the physical pump, and this is the actual heart muscle that includes the 4 chambers, our 2 atria and our 2 ventricles. We have valves. We have our mitral valve, tricuspid valve, aortic valve, pulmonary or semilunar valve. We have our coronary arteries. Those coronary arteries wrap around the heart itself to oxygenate the heart. One thing that I need you to know and I want you to understand is that the heart muscle has its own blood supply, which is the coronary arteries. Okay? Those coronary arteries are the main oxygen and blood supply to the heart muscle. Okay? The fluid circuit, this describes the dynamic action of blood flowing through the atria and ventricles, the lungs, and the entire vascular network, which generates blood pressure. Then we have the electrical grid. This is your cardiac conduction system that describes the intricate conduction system that provides the electrical impulses for each heartbeat, creating the heart rhythm you see on an EKG. And this is what we will be going over probably Wednesday when we go through the cardiac conduction cycle. You are going to see some like repeated stuff. What I did was kind of combine my previous PowerPoint that was made by somebody else to the PowerPoints that I made with Notebook LM. So I kept both of them, which is why this is that's 81 pages long. I kept both of them because I wanted to see which one worked better for you. I didn't want to take away and then you'd be like, oh, this doesn't make sense or this doesn't work for me. Okay. And I won't take offense to it if you like the other ones. So this is the other PowerPoint that is just telling you exactly what I just told you with nice pictures. And I feel like the pictures were nice. So this is just a picture that depicts the parts of the heart, and it also includes the coronary arteries, which is what I really like about this picture. And we're going to go through the blood flow of the heart too. I'm just going to put you in. I feel like you need to sit in a bit. Sorry, Ginger. Okay. So the coronary arteries feed the heart muscle, the blood supply to be able to function. Okay. So like I said, these coronary arteries literally wrap around the heart muscle. There is no other muscle like this that has its own arterial blood supply. Okay. These arteries don't go anywhere else. Its main job is to supply the heart muscle with all of the oxygen and blood flow that it needs. Okay. So when a person has an MI, that happens when one of these coronary arteries gets blocked off and shuts down blood flow and oxygen to that part of the heart muscle. Depending on how severe that blockage is, depends on how quickly or not we are able to intervene, save our patient, or not intervene, which my father-in-law had a massive MI sitting at the kitchen table. There was no getting it back because the blockage was so severe. But then you have people that, oh, I had an MI, I went in, I had a cardiac cath, and then I got a stent, and oh, I'm fine, right? So it all depends on the degree of the blockage. So this is our beautiful little ticker, okay? Hopefully we've all seen some picture like this before, all right? So you have your superior and inferior vena cava. That goes down into your right atrium, okay? Your right atrium contracts, which then causes that blood to go through the tricuspid valve and into the right ventricle, okay? When the ventricles contract, the blood that's in this right ventricle goes out through the pulmonic valve to the lungs to be oxygenated, okay? Now I need you to see something. What did we say about arteries and veins? Who carries oxygenated blood? Arteries. There is one place, only one place in the entire human body that it is opposite, and it is here. This right ventricle goes out through the pulmonary valve to the pulmonary artery. This is not oxygenated blood. This is blood that needs to go to the lungs to get oxygenated. It goes through the pulmonary artery. When it goes down into the lungs, into those capillary beds to get oxygenated, where it has oxygen and carbon dioxide exchange, right? It then comes back into the pulmonary vein, which is here. I don't know why it doesn't have a thingy. But these little 4 arrows, 1, 2, 3, 4, the little red arrows, that is the pulmonary vein. Okay? So it comes in through the pulmonary vein into the left atrium. When that left atrium contracts, it pushes the blood through the mitral valve and into the left ventricle. When the left ventricle contracts, it then goes out through the aortic valve, through the aortic arch, throughout the body. Okay, I feel like that was a lot of words, but I think I have. Ooh, look. Thank you, Notebook LM. Look what it just did for me. So this gives you step by step, step 1 all the way through 13, the blood flow of the heart. You should know this. Okay. I would put a big fat star on this picture. Questions about the path of blood flow through the heart? So this is just a nice picture that shows you the entire vascular system. Not entire, but a lot of your core vascular system. So we already said our arteries transport blood containing oxygen and nutrients from the heart to the body tissues, and our veins return the blood to the heart after cellular exchange of vitamins, minerals, nutrients, and oxygen. So that carbon dioxide and oxygen exchange happens here down in those lower capillary beds in the lungs, right next to your alveoli, right? You have your alveoli, and right next to them is the capillary beds, and they do a little diffusion action back and forth with carbon dioxide and oxygen exchange. Okay. I also need you to know this. This is very important. This is the cardiac conduction system. Okay. So electrical impulses send signals to the rest of the heart muscle, causing a contraction. You have a normal heart rhythm, which is your sinus, normal sinus rhythm. Okay. And then we have abnormal heart rhythms, which we're going to discuss later on, which include sinus bradycardia, sinus tachycardia. We have atrial rhythms like AFib, A flutter. Then we have ventricular rhythms like SVT. We have VTAC. We have VFib. Then we have junctional rhythms, which, by the way, we are not going to spend a lot of time on junctional rhythms, okay? Because they're complicated and I hate them. So the cardiac conduction system starts with the SA node. The SA node, what is the other name for the SA node? Anybody know?
Pacemaker.
The pacemaker.
Pacemaker of the heart.
Yes, it is the pacemaker of the heart, okay? Your SA node kicks off your cardiac conduction system, okay? So the SA node goes to the AV node. By the way, this is your sinus atrial node. This is your atrial ventricular node. Okay, that's what those letters stand for. Then it goes right here to what we call the bundle of His. The bundle of His then branches off into the Purkinje fibers, and those Purkinje fibers wrap around the ventricles. Okay, so you see how these are different colors? The first two are red, the other two are blue. So these first two are for atrial contraction. SA, AV are for atrial contraction. So if you have atrial arrhythmias, where do you think the problem in conduction is? Within one of those nodes. Okay. If you have a ventricular arrhythmia, you would think that the conduction problem could be down here within our ventricles. And the conduction system, the electrical impulses that control ventricle contraction. Okay. Make sense? I need you to know this pathway. Okay? The path to blockage begins silently. So our healthy arteries, they don't have anything sticking to them, sticking to the sides of them, okay? They're nice and patent. There's nothing blocking their way. There's no sticky platelets that like to aggregate together, okay? Then we have atherosclerosis. So atherosclerosis is when you have plaques that are building up and you also have hardening that's occurring, okay? And then if we are within those coronary arteries and that blockage gets really intense, right? And it starts blocking a lot. And remember, we talked about sticky plaques before, that fatty buildup. I already said the word, it's sticky. So what happens? Things stick to it. So if a platelet gets stuck in there, and then what do platelets like to do? Aggregate, right? They like to aggregate together. They're like, oh, you're over here, let's party, and we're gonna get a lot of platelets together. Well, guess what? The more platelets you have, the more blockage you have. So then this turns into a big fat blockage that's turning into an MI. Okay. So coronary artery disease is the clinical consequence of atherosclerosis where plaque buildup from cholesterol deposits. Those deposits impede blood flow and deprive the oxygen or the heart of oxygen. So we have non-modifiable risk factors that are age, gender, ethnicity, family history. These are things that we can't change. Okay. Modifiable, we can quit smoking, we can quit drinking, we can lose weight. Okay, we can decrease our stress. Maybe I haven't figured out how, but somebody needs to tell me. Right? Do some meditation, some guided imagery. Okay. Diabetes and high cholesterol. Remember, the disease can be modifiable. Okay.
Wouldn't it be only type 2?
That's a good point. Yeah. So she said,
with this, I must say this, there is no 1 or 2.
right. So Ranea asked, would this only be type 2 diabetes? So when you think about complications of diabetes, those complications occur from untreated hyperglycemia.
Okay, so I was
right?
thinking because 2 you could get rid of, 1 you're always going to have.
Which is very valid. She's saying that type 2 can be reversed and type 1 is an autoimmune disease, which we cannot reverse, which is very valid. But we are talking about diabetes as a comorbidity. The complications of diabetes. So that was a very good question. This is pretty much the same exact thing, just made by a notebook LM. But this also includes the clinical response. So you have symptoms that include angina. Angina is our medical terminology for what? Chest pain. We have different types of angina, which we're going to talk about. Okay. And this specifically is angina that does not resolve with rest. That's the bad kind. Okay. Shortness of breath and diaphoresis. Medications, we can use antiplatelets, which aspirin, that really should say antiplatelet aggregator, okay, which is our aspirin, our clopidogrel, aka Plavix, okay. Then we have antilipidemics, which is your statins, okay, atorvastatin or Lipitor. By the way, I found out, Ms. Fresman told me, which I'm glad she told me, because I thought that the NCLEX listed both drug names. That's false.
I just give you the generic.
They only give you the generic name. I literally just found that out like 2 days ago.
Good to know.
Good to know. Very good to know. Put that in your back pocket. And nitrates. So then your procedures, This is a stent placement to try to open up a blocked artery. So they go in with a guided wire. This is a balloon that they blow up to open that area. And then they place a stent here to keep it patent. Okay. But this page also includes nursing intervention. So your patient education is going to be the priority because all of these things are going to lead into a possible MI. Okay. Decrease blood flow. And the only way to, I guess, I was going to say we're prophylactically, you want to prophylactically treat this. You want to prevent MIs. Okay. And then afterwards, after you have an MI, you want to continue preventing having a second MI. Okay. So we're always in that place of prevention when it comes to MIs. All right. So smoking cessation, moderate exercise, stress management, decrease your sodium intake, decrease alcohol, increase your fiber, fruits, and vegetables. Okay. And take your meds. Compliance with medication is important.
And guys, compliance with medication can be a problem, especially in the beginning, because it makes them feel fatigued. They may urinate more. There's just a lot of side effects that come with those medications. I have a rare heart condition, and my blood pressure, we keep my blood pressure like 90/60. And I'm fine with that now. I tolerate that very well. I function without any problem. But the truth is, in the beginning, it was very hard. I was very fatigued all the time. I was tired. I still change positions very slowly because I will, especially at night, I'll end up like into the wall if I stand up too quick.
And what do we call that? Orthostatic hypertension.
Yeah. Yeah. And so it's just, I think it helps when we educate our patients realistically. Tell them, hey, in the beginning, you might feel tired, you might feel fatigued, these type of things. But it's going to get better. And if they know that, they're more likely to stay compliant. If we're honest with them, if we tell them, hey, this could happen, then I think they're prepared. And when those things happen, they're go like, okay, well, they said this could happen. So, they expect it. It's setting those expectations. Setting those expectations for sure. And just really, I have unstable angina because of my heart condition, and which I know we're going to talk about, but and anytime I end up hospitalized, which happens on occasion, and they adjust my meds, I go through that again for a period of time. But now I know that, you know what I mean? But nobody really talks to patients about these things. And so just be realistic with your patients about what they should expect or can expect. The other thing is the low sodium diet. Let me tell you, if you have not tried to do a low sodium diet, you should practice it for about a week.
I would hate it.
Yeah.
I love salt.
And just things like I used to do patient education for CHF. I have lots of years of CHF teaching, patient teaching. And like I had a patient who gained he had gained 6 pounds overnight. We were like, whoa, what's going on? And so he was like, well, I was out with my daughter. We were running errands and we got we stopped and got Arby's. And I was like, okay, so I'm talking to him about like how he really has to watch his sodium today and all that. And I'm Googling at the same time. One roast beef sandwich at Arby's has something like 4,500 milligrams of salt.
That's your whole day.
What in the world?
Fine.
Why is it? That is why it's so good. But why? I love
That's
salt
not
and bread.
fair.
So
That's
when
crazy.
I told him that, he was like, what? And so again, just saying like, hey, if you're gonna go out and eat out, look at the menu ahead of time. Almost every restaurant will tell you their nutrition information and find the thing that you like that has like the least amount of, like just being realistic about those type of things. But yeah, I was actually blown away by how much sodium was in that sandwich too.
That's insane. So also, I want you to think about why is the patient symptomatic when you change their meds? Talk to me. Why? What happens when you lower your blood pressure or your heart rate? What happens like physically?
Your heart's not working as hard as it would before. Like your body was used to working at that
Okay.
stable.
So your heart and your blood pressure and your body are used to working at a high level. And then we decrease it.
It's a shock.
So what is lowering?
The workload.
Blood flow. The blood pumping in.
What do we call that?
Cardiac output.
Cardiac output. What happens when you have a decreased cardiac output? We have less blood flow to
The brain.
The head.
our
the
brain,
brain.
which means we have less what? Oxygenation to our tissues, right? So if your patient is feeling fatigued, lightheaded, what does it all come down to? Decreased oxygenation. It all comes back to the oxygenation. Always.
That's fine.
Nate, we need more oxygen to your brain, Miss
We
Linda.
do, because the metoprolol doesn't do much for my blood pressure, but my heart rate, it slows it down. Like,
That's a wonderful point. She said metoprolol doesn't do a lot for my blood pressure, but it slows my heart rate down. Because metoprolol, which is a what?
beta blocker.
A beta blocker, works on contractility. Okay. Is it an antihypertensive? Yes. But does it work more on contractility?
But it's not a first line antihypertensive. Just so you guys
No,
know,
it is
that is not a beta blocker is not something that they're going to pick first to treat hypertension.
Correct. But if you had an arrhythmia, they're going to pick, most likely pick metoprolol as one of your first, maybe as one of your first lines.
They put me on combination off the rip.
Yeah. She's like, combination for me. Okay, so coronary artery disease, complications from atherosclerosis. We already talked about this and we already talked about that. Okay. We touched briefly on what causes the MI, right?
Mona.
So have you heard of the term MONA?
No, but I like it.
MONA, she stands for morphine, oxygen, nitrates, aspirin. You go into the ED complaining of chest pain, guess what? MONA. Okay? So, what is it? This is myocardial tissue death due to a complete blockage of blood flow in one or more coronary arteries. If you have greater than 30 minutes of blockage, this can cause permanent damage. Permanent damage in what we call ischemia. What is ischemia?
Death.
The death of that tissue caused by lack of oxygenation, lack of blood flow, lack of oxygenation. Okay? So, this is sudden crushing chest pain that may radiate to the jaw, arm, or shoulder. I want you to know this. Not only is it a good to know, it's a need to know. Women may experience different symptoms that include extreme fatigue, nausea, and shoulder and neck pain. You have a woman that comes in and she's like, I've had indigestion for the last week. Guess what? She's getting a cardiac workup. Chelsea, she's our paramedic. Her eyes just went, yup. Yup.
That actually
The
happened
other
with my
thing is
coworker.
a sense of impending doom.
Yes. She said the other thing is a sense of impending doom. If your patient ever looks at you and looks at you dead in your face and says something's wrong, I'm telling you something is wrong. So I'm going to die. Something is happening to me. You better believe them. Could it be someone overreacting? Yes. But a sense of impending doom is your body's way of saying, I'm dying and somebody needs to do something about it now. It is so real. It is so, so real. So why morphine? Why morphine? It does decrease the pain. It also decreases your oxygen demands. Okay. So not only is it for chest pain, it actually helps with the oxygen demand that's occurring in the body. Okay. So it works on two different ways. It's not just for pain.
And
Oxygen
morphine does
obviously.
cause, oh, sorry, go ahead, Jessica.
No, you're fine. It causes vasodilation, doesn't it?
It does.
Yes.
In particular, it works very well on coronary arteries for vasodilation.
Yes. So
Write that down.
absolutely write that down. So not only does it work to decrease your pain, it decreases your oxygen demand and also causes vasodilation
In your
within the coronary arteries, which is where we need it, right? Then we have oxygen. We obviously are going to put our patient on oxygen because we need to get as much oxygen to that heart muscle as we can, as possible. Okay? Nitrates. This is for vasodilation, right? The morphine is only going to do so much when it comes to dilating. We're going to get some nitroglycerin to dilate those arteries. Okay. What happens when you vasodilate?
Red.
You can turn red. Why?
The blood is going to the surface.
The blood is rushing to the surface. What else? You get a headache. What else? What happens to your blood pressure?
Oh, it plummets, goes down.
Down. Okay. So now we're looking at possible hypotension. When your patient's having an MI, they're having active pain, that blood pressure is going to be up. Okay. So is it going to be severe hypotension where they're plummeting and they're going into like hypotensive shock? Probably not. But it is going to cause a decrease because of that vasodilation. Okay. And aspirin prevents clotting. Why? What does aspirin do?
It's a
Antiplatelet aggregator.
That's such a word.
It is such a word, such a vibe.
And I tried to remember
Okay.
that too.
So
Alligator.
then we have definitive repairs. Okay. So we have a percutaneous coronary intervention, which is short for PCI. This is your patient going to the cardiac cath lab. Okay. This is where you're getting that stent. This is where they're trying to go in and see where those blockages are and see if they can open them up. Okay. And then you have a coronary artery bypass graft, which is what we call a CABG. And these are the procedures that restore blood flow. If you have a stent placed, can you go have a CABG the next day?
Yes.
No.
No?
Absolutely
Why
not.
not?
I learned this.
What if the stent doesn't? What if it fails?
That's a great point. That's a great point. But the thing that I learned, because my husband's cousin's 37-year-old husband with 3 kids had a massive MI at 37 years old.
Oh, this is
And he had
an advanced farm.
Yes, see, Ginger remembers? It happened when we were in Advanced Farm. And he had 3 stents placed. And I was like, oh my God, he's going to need open heart surgery, right? And he does. He absolutely does. But then they said, I was talking to one of my best friends. She works in the cardiac cath lab downtown Youngstown. And she said, well, he can't have open heart for 3 months. And I'm like, what? Why? The stent has to mature. And you are put on drugs like Brilinta and anticoagulants so that you don't have blood coagulating on that stent, and that stent also has time to mature and stay patent. Okay, so those drugs are not going to allow you to go in and have a CABG in the next week. You have to have that stent matures over that 3-month period, and the compliance with those medications is extremely important.
Okay, well, I guess that's because I didn't have the information, but I watched the open heart surgery. The man that I watched, he ended up getting a quadruple bypass.
Yeah.
But he had already had stents.
Yes.
So they must have been there.
Probably.
For some time. Like I didn't get no information. They told me scrub on up and come in here and watch it. So I got to see one, but I didn't know. I just was like, well, yeah, you can, because I watched it.
Yep.
Like I watched him do it.
The first time I ever saw a human heart beating in surgery, I cried. It was like one of the most beautiful things I've ever
Oh,
seen.
very interesting.
I mean, it's because first of all, you don't ever really think that you're going to see like in person, with your own eyeballs, like it's right there.
I was amazed.
Like you could touch it. I mean, don't touch it, but you could touch it.
I just was like, thinking that these people, they're dead. Like you are dead.
It's amazing.
Like you was alive when you went in, and you're dead.
And they put you on pipe.
Yeah, I mean, all your blood is running through a machine. You got people turning your lungs on
It's
and
insane.
off. And I mean, just make the blood pressure 88/72, and boom, there it is. And they like stop the lungs, and they just deflate. And I was just like, they really did.
Yeah,
It's
scary.
And now we gotta shock you and bring you back up. And when he took the heart out, and he had it in his hand, and he just put ice chips on it, and it slowly stopped beating. And then he just started sewing stuff up like they don't. I thought that
Like it's like no big deal. It's like
they don't do it.
it's just a regular Tuesday.
Just start sewing it where they want. And I was just like, now this is wild.
Can you guys hear her? Or is she breaking up?
That is wild. Now that was like the best thing.
A little
I-
bit.
That's
She was just
years ago, and I talk about it every chance I get because I just ain't never seen nothing like that. Like the
Yeah.
lungs, like how large they are.
They are
take up
so
the
big.
whole chest. Like
So-
they are big.
She's talking about when she we can hear. Okay, good. Somebody went like this and I didn't know if you could hear it all. If you ever have the chance to go into an OR in shadow, you should absolutely take advantage of that. Absolutely. Okay, so what is important to know about this slide? I need you to know that the coronary arteries feed this muscle. Okay? It has its own blood supply.
So it need
Okay? 100% blockage of the coronary artery causes those cells to die, which is what we call ischemia. If there is not an intervention as fast as possible, you could have permanent damage occur after 30 minutes. Okay? Mona is important. Mona is that girl. Okay?
So that's an intervention to prevent damage, or they need to have surgery.
Mona
is the immediate treatment.
is the immediate treatment that occurs so that you can buy time to get your patient into the cath lab. Because guess what? It happens after hours. You're waiting for the cath team to come. By the way, they have to live within 30 minutes of the hospital. Okay. Sarah says we give this an EMS when we suspect an MI. So go ahead.
So we know Mona is the immediate treatment.
Yes.
And you said that's the buy time.
Yes.
And I guess it's maybe not dumb. I think I know the answer, but I'm gonna ask it anyways. You have to go to the cath lab before you can go and get a bypass, because that's the only way they're gonna know how much blockage you had and whether or not it can be fixed less invasively.
I want to say yes, but I also want you to know that there's always going to be a variable. I say that all the time,
Okay.
right? It's
So-
never going to be always or never. There's going to be a variable.
I was gonna say,
Brandy,
I
go
don't
ahead.
know, if a patient's having a STEMI, then yeah, they're going to cath lab, no questions asked. That's where they're going. And it's gonna be in a short amount of time. If they're having a non-STEMI, not always, depending on whether there's EKG changes, if they're stable. So if a patient is stable and is not having EKG changes, they may choose just to treat medically and not do a cath or schedule a cath for later or within 24 hours. But it's not going to be emergent typically when you are looking at a non-STEMI. Does that
And when we go over, yeah, definitely. when we go over arrhythmias, we're going to talk about the difference between a STEMI and an NSTEMI, which is also a non-STEMI, right? And how that treatment can change. And that's a really good point. But just for this purposes of saying this patient is in immediate danger and needs to be treated immediately, Mona is going to buy you enough time, vasodilate enough to oxygenate the heart muscle to get that patient to be alive by the time you get them to the cath lab. Okay. That makes sense? Mm-hmm. And then I want you to know the difference between the percutaneous coronary intervention and a CABG, which is a coronary artery bypass graft. Okay. So that the CABG is where they literally take other arteries and graft them to your existing coronary arteries like a bypass tunnel. So this guy's blocked. Okay, I'm gonna get a vessel from somewhere else. I'm gonna attach it here. I know you guys, can you see me pointing? I'm gonna attach it up here, and then I'm gonna pop it down here, and it's going to bypass this whole spot.
Yep, so the blockage stays there.
So the blockage is like, you suck. You're not working no more. I'm bypassing you. Okay. So we have, Brandy, can they do a single and double? Or is it only a triple and quadruple?
No, they can do a single. They can do a single. They can do a double. They can actually do, my husband's oncologist had 6 arteries bypassed. He had to go to Cleveland Clinic. He has like a genetic condition, but yeah, he had a CABG times 6, and nobody in this area could do it. So they sent him to Cleveland Clinic.
I want that shit.
And Brandy, I know that your husband has a wonderful oncologist, but man, does that make me nervous that my surgeon needed 6 coronary bypasses.
Yeah.
Oh. All right. Any questions on an MI or Mona? This next page is just a reiteration of what we just talked about, just kind of in a more simple way. And I do also want you to remember that it's important that women can have different symptoms. Okay. And I want you to let me know which pictures you like better.
I actually like them all.
You like them all?
Yeah, literally.
Yeah.
I was gonna go to the next one. They might have a little tidbit on it.
Right?
The first one,
Like,
yeah.
do it because I didn't want it to be like so repetitory that you're like, oh my god, we just did this.
Like then that one is there.
Stick it in your brain. Yes.
The other thing I will never forget, guys, and this taught me really quick to be careful of what I say. I had a patient who came in with a STEMI, and our cath lab was awesome, man. We had door to table times in like 15 minutes. They rocked. And I had a patient, a female who came in, she was having a STEMI, and she looked at me and said, "I'm gonna die." And I said, "No, you're not. It's good. Cath lab, they're going to get you. They're going to get you on that table. It's going to be fine." That woman died on the cath lab table. I will never say that to another patient again. But she knew. She said, I'm going to die. I'm going to die." And she kept telling me that. So that sense of impending doom is a real thing.
Yeah, it is very real. And you should absolutely take it very seriously when your patient says that to you. This is kind of off topic. I had the same impending doom also when I had my first daughter and my placenta ruptured. Yes. I lied in bed. Like, Chelsea said that she had the same sense of impending doom when she had a placental eruption. Also, if I hope you learned about in OB a amniotic emboli. Yeah.
Yeah, we did.
Yeah, an amniotic embolism is when amniotic fluid gets into your circulatory system and will cause your patient most likely to cardiac arrest. It is one of my, which I'm not having any other babies, but it was a huge fear of mine. And it is so important. It's so important to start CPR almost immediately, as fast as possible, and get that baby out as fast as possible when your patient is experiencing this. And the video that I saw that caused all of my horrible anxiety when I was pregnant was a woman that had survived an amniotic embolism. And she literally said, right before it happened, she said, my nurse was standing next to me, my husband was on the other side of me, and I looked at my husband and I said, something is wrong, I'm going to die. And she went out and she cardiac arrested right there.
I don't see what maybe I remembered it wrong, but the emboli came after the baby was delivered.
It could happen that way also. It could happen before and after. Yeah.
See, they didn't explain that to us, OB, that it could happen while the baby was still in utero.
I think it's more common for it to happen after because, and I think the membranes have to rupture.
If they ruptured the membranes, that was what it was. If they
After
ruptured, it's something about the way that they would rupture.
Yeah.
Maybe too early,
Because
something or the other.
I also want you to think about when you're giving birth or after birth, that's when the trauma occurs, right? It doesn't usually occur during labor while you're dilating. It happens while the baby's coming out, when you tear, when you have openings in your circulation. When you have openings in your circulation is when that emboli could occur, because that amniotic fluid can go into your circulatory system.
So C-section is like really.
I don't know if it's more, I don't know. I would have to look into that if it's more common with vaginal or cesarean.
I'm just saying.
I bet you it's more common with vaginal.
It is, and that's why I'm saying the cesarean section seems
So,
like
it's safer. Go ahead, Brittany.
Working in labor and delivery is
Oh yeah,
more
Brittany does work in
common.
L&D.
Yeah.
I want to hear
We
what she says.
so we have not seen an AFE in a while in my unit.
Yeah,
Knock on all the wood,
girl.
because we're not bringing that in here.
Yeah.
But
We are
we
not
see it.
putting
Our
that on our
surgeons have
2026
said
bingo card.
no. Our surgeons have said that we see it more commonly with a repeat cesarean section or a velatinous cord insertion vaginally, because the way the bag ruptures, if it tears where that vein is, that it opens to the circulatory system. So like anytime we have a mom who ruptures but then starts bleeding, we run them straight to the OR.
Yeah, that makes sense. That makes sense. That's
I
a good
work on
point.
the too. We actually do like how you do with them dummies and stuff.
Oh yeah.
We did one on an AFE so that we know what to do if that happens. Even like
Absolutely. So in the, she's saying that they do like education and like a mock situation, just like in the hospital you do mock codes. When we worked in the OR, we do mock malignant hyperthermia situations because that happens in surgery, right? So on an OB floor, I hope to God you do mock scenarios of AFEs, because that, I swear, that was absolutely one of my worst.
We do.
nightmares.
We do mock scenarios for AFEs, cord prolapses, placental abruptions. We just added a uterine rupture because last year we actually had a uterine rupture with the placental abruption. And when we opened mom, baby was like in the abdomen, still in the sac, but not attached to anything. So we actually have 6 OB drills that we do throughout the year. And we are invited to go to all of them.
Did the baby survive?
The uterine rupture and placental abruption? No. No, it did not.
All right.
The neonatologist told us that the baby had no chance of survival unless the rupture happened while we were on the OR table. So we kind of anticipated the worst anyway.
That's so sad. Okay, let's do this last slide and then we're going to go to lunch. Because this wraps up our MI. So symptoms, we've already talked about this: shortness of breath, indigestion, tachycardia, diaphoresis, pallor, right? Because we're vasoconstricted, right? When we're having an MI, because the body is trying to get as much oxygen to the core as possible. So we vasoconstrict everywhere else to get the blood flow to the core. Okay. Women, we've talked about this multiple times. Okay. Nursing interventions, we have strict bed rest, supplemental O2. We want to monitor vital signs, EKG, lung sounds, a surgical site if there is one. If you go for a coronary, the PCI, the percutaneous, where are we going? Right, but where is our surgical sites?
Groin and
Femurs. Groin, so our femoral artery.
And then your, what is it, the radio?
Or
And the
our
rest.
radial artery. Yes, so we either are going to have a site in the right or left radial artery or the right or left femoral artery, okay?
And
So make sure we're
radial's
paying
becoming
attention.
much more popular.
Yes, yeah, because what's dirty?
Groin.
Dirty, groin is dirty, okay? Do we still see it all the time? Yes. Okay, I know you had an instructor that told you that it never happens, that femoral access only happens in emergency. That is not true. Okay, femoral access happens all the time, every day. All right. Labs, especially cardiac enzymes, we're going to talk about troponins and other labs later on. And chest pain. Immediate treatment, we already talked about Mona. I want you to know it. Next interventions, we have thrombolytics. This can happen, okay, for an MI. It's not super routine where you give a thrombolytic for an MI. Usually when we're talking about thrombolytics like TNK or tenecteplase is when we're talking about an embolic or thrombolytic stroke, right? Ischemic stroke. But sometimes it can be given for an MI to dissolve the clot, okay? You want to know your procedures, your PCI versus cabbage, okay? And or not really versus. And then stabilization and prevention. They're definitely 100% going to be on an anticoagulant, okay? But they may be on a heparin drip after, before or after. Beta blockers for sure to control that contractility, especially if there's an arrhythmia present. ACE inhibitors, they're probably hypertensive, okay? Calcium channel blockers. Now, remember, we're bringing it back. I need your brains to start working after this break, right? We have two different types of calcium channel blockers. What are they? We have the one type, that's for hypertension. We have the other
Verapamil.
type. Yes, girl, verapamil and what else? Cardizem. Yay! That is more for your arrhythmias, right? Your cardizem, your verapamil are more for your arrhythmias. The other classification of calcium channel blockers are for hypertension. Okay, so you have two different kinds. Okay, then you have your statins because we need to, if this is being caused by cholesterol, by a high cholesterol and increased plaques, we want to try to control that, lower the total cholesterol. Okay, and then antiplatelets, which is going to be your antiplatelet aggregator, your aspirin, your daily aspirin. Okay, so I want you to take a look at this. Love it. We're going to be talking about these drugs a lot. Okay, questions on MIs? Already?
Yeah.
I mean, it has been. We did math. We already did a lot. So
I think I never liked the heart. And
now you do. She does now. Okay. It's 12:04. Let's go to lunch. I want you to be back here. No, 1:00. Get out of here. By 12:40.
Thank you.
Hey, thanks.
This?
Yeah, it's after the second one, the second one actually.
Okie dokie. Are we back? We all come back now?
You said you got this on Amazon?
Yeah, I got both on Amazon.
This will be bring your blanket gonna die.
It's nice. And it has a hood.
I'm not wearing it like a poncho, I'm using it as like a blanket.
You do you, girl.
It's work. So.
I get rid of my phone too. I need to get mine and get this another one instead of getting some.
Okay, I have a question for you guys. Do you like being here where you are right now in front of my projector, even though you can't really see it? Or if I put you over there by the computer, either way, I'm gonna like I won't walk away too much, but when I do walk away, my voice gets lower for you. So I'm just trying to figure out where the best place is for you.
I think where you have been doing it, like now, is
good.
great.
Yeah.
It's what we can hear you.
Okay,
agree.
good. Let me get my hot spot.
For the visas, can you change the due date on them?
Oh, I have to go in and change all the due dates on the, yeah. I have,
ATI, it takes 24 hours after you start that, or it's to allow you access.
Latasha said for anybody repeating, it takes 24 hours after they reset your ATI for it to like let you go in there and do whatever.
That's unfortunate. They said 24 hours, but I got it.
So she said they say 24 hours, but she got it before 24 hours. So hopefully they get it, you know.
I think that's so crazy to have to do that stuff again.
I know.
This packet, these slides are for today and Wednesday.
Yeah, and EKGs. I'll print the EKG ones.
I think I already got. I think we got the EKG.
Yeah. No, that's the worksheet. I'm talking about the actual PowerPoint. Yeah, the actual EKG PowerPoint.
Is this what you're talking about? We're gonna work on.
That's the worksheet, yeah. I do, so once we go through a lot of the EKG PowerPoint, over the weekend, I want you to do what you can up until that like stopping point where we didn't, like say we don't get to heart blocks. I don't want you're not required to do heart blocks because we haven't even talked about it yet. You know what I mean? Oh, I never stopped sharing my screen. I didn't know that.
I think you did, because when you came in here, you said, let me fix this before I forget.
No, recording.
It does.
Be careful with the food out because bowling already is in here.
Already did, I need them.
Yeah. Okay. So everybody can see my screen? Yeah, okay. All right, so we're just gonna touch quickly on cardiac arrest. We're going to talk about it much more when we get into EKGs and when we talk about ACLS protocol, and medications for cardiac arrest and all those fun things. But quickly, just so it's on your radar, cardiac arrest, this is the abrupt cessation of cardiac activity. In someone asymptomatic up until the moment of arrest. Okay, so this is literally the cardiac conduction, those electrical impulses, they just stop. Okay. This can be asymptomatic. It is not always asymptomatic, but it can be asymptomatic. The diagnosis is made based on the lack of your human having a pulse. There is no heartbeat. Okay, there is no electrical activity. Medications, this is going to be your ACLS. Like I said, we're going to go into that in depth with our EKG stuff. And then other interventions, of course, is going to be CPR. That's what we want to do immediately. I don't care if you have a ambu bag or your patient's being intubated or you're waiting for blah, blah, blah. The very first thing you do, always, 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 is jump on the chest. The faster you get to CPR, the more chance your patient has of recovery or getting ROSC, which is, oh my God.
That means they're treating it again.
I know, I'm
Return of spontaneous circulation.
Return, thank you. I'm like,
That's all.
R. Come on, Jess, R. Return of spontaneous circulation, which is what we call ROSC, ROSC. Return of spontaneous circulation. Thank you. By the way. Okay, so like I said, we will talk about this a lot more with EKGs and ACLS. Okay, when airspace fills with fluid, this is what we call pulmonary edema. This is an abnormal accumulation of fluid in the interstitial space and alveoli of the lungs, and this impairs gas exchange. Okay, if there's a bunch of fluid surrounding your little alveolar sacs, gas exchange cannot occur. Sorry, I'm pulling up my DoorDash to see where they are. Oh, they're here. 8904. Okay. I forgot. She's so great. Okay. So this can be a medical emergency. And when it is, we call this flash pulmonary edema, which means it happens very, very quickly. And then all of a sudden, your patient is in extreme respiratory distress and they cannot move any air because it happens so suddenly. We call it flash pulmonary edema. Okay. There are different levels of pulmonary edema, or some can refer to it as pulmonary congestion, right? So a lot of fluid in the lungs. This impaired gas exchange leads to hypoxemia. And the fundamental clinical challenge is to determine the origin of the fluid. So why is it happening? Okay. Is it happening because your patient is having a transfusion reaction to blood? What is that called? When it impairs your lungs and causes pulmonary edema. It's not taco. Trolley. Yes, transfusion related or transfusion something associated lung injury. Acute. Transfusion related acute lung injury. Ha! Trolley. Thank you. This can happen from a large amount of IV fluids given over a very short period of time and the patient can't compensate. So all of a sudden it just dumps into the lungs. Okay. Scary, very scary. Okay. So this is what we call efficient gas exchange, where the alveoli are here. These are your capillary beds, and then you have exchange of oxygen and carbon dioxide occurring. Okay. And this is where we have pulmonary edema, where there's fluid in between the alveoli and capillary bed. So that oxygen and carbon dioxide exchange cannot occur because it can't cross water, unfortunately. We're not crossing the sea. Okay, 2 origins, 1 destination. So we have 2 different types of pulmonary edema. We have one that's called cardiogenic edema. We have non-cardiogenic edema. So cardiogenic, the pressure problem, this is the heart's failure to pump. This is all because of the heart failing to pump effectively. So the heart's failure as a pump creates a backup of hydrostatic pressure, and it forces fluid from the pulmonary capillaries into the lung space. This is from heart failure. Okay. Cardiogenic, cardiac, it's caused by the heart. Non-cardiogenic, it is not caused by the heart. So the pulmonary capillaries themselves become damaged and leaky due to direct or indirect lung injury, allowing fluid to seep directly into the alveoli. So this is not caused by heart failure. This is caused by injury within the capillary beds. Okay. It's important for you to know the difference between the two. One is caused by the heart failure and one is not.
Excuse me, Ms. Simmons, what would be like an example of a non-cardiogenic?
That's a good question.
ARDS, DIC.
There you go. All right. We're going to talk about ARDS. TIC?
Yeah. What's that?
What's TIC?
DIC.
Oh, DIC.
Yeah,
D as in dog.
DIC.
DIC. That's a good one. Yeah, we are going to talk about ARDS extensively next week when we do our respiratory PowerPoints. ARDS is acute respiratory distress syndrome. And that is when you really truly have lung failure.
Yep, sepsis would be another one. You can see flash pulmonary edema with sepsis, renal failure, acute renal failure. So there are a lot of things that can cause non-cardiogenic pulmonary edema.
I like having this backup. Brandy, I like your backup.
When she's on it too, like
My
She is
pleasure.
on it. She has so much experience, so it's just like,
Thank you.
just quick. Okay, so this is looking closer into the cardiogenic shock, and it also lists causes. So the core concept of cardiogenic shock is that the left side of the heart can't pump blood out of the heart, so blood backs up into the lungs. We're going to get into heart failure more, and I'm probably going to let Brandy kind of take over that one because she used to teach for the CHF clinic as her main gig. So she's much more experienced than I am with CHF. So the cascade, this backup increases blood volume in the pulmonary circulation. It leads to a sharp rise in pulmonary pressure. This high pressure physically forces the fluid out of the capillaries and into the interstitial space and alveoli. So when you think of left-sided heart failure, I want you to think left lungs, LL, left lungs. Okay? So that left-sided heart failure causes backup of fluid in the lungs. The primary causes would be acute exacerbation of chronic heart failure, an MI, severe uncontrolled hypertension, and cardiomyopathy.
I explain heart failure and the concept of heart failure almost like a racetrack. So if you think of like if there's an accident, right, it causes a traffic jam. Well, that traffic jam occurs behind the accident, not in front of it. And so when you think about what's not working, so if our circulatory system is a racetrack that goes round and round and round and round, which it does, right? If that left ventricle is not working and you think of normal flow of blood, if my left ventricle can't effectively clear my blood supply or the blood in the ventricle, then what's directly behind the left ventricle in your normal blood flow?
That's where your pileup's going to happen.
So your left atria is directly behind your left ventricle. Directly behind your left atria is your pulmonary vein. Pulmonary vein, I'm right. Your pulmonary veins, okay? Behind that is your lungs. Behind that is your right ventricle or your pulmonary artery. Behind that is your right ventricle. Behind that is your right atria. And then behind that is your normal circulatory system. And so this is why if you think about how that blood flow normally goes and where that backup starts and where it pushes that back flow into, this is why left heart failure very easily causes right heart failure, systemic heart failure, if it's not treated correctly, if it's not managed appropriately. And that's why it's so important that, like, Ms. Simmons told you guys, you have to understand normal blood flow, because if the left ventricle isn't working, it makes sense why our left heart failure starts to have lung symptoms, because all that fluid is backing up into the lungs. Okay? If it's primarily right heart-sided failure, then you think of the right ventricle. Well, that right ventricle goes to the right atrium behind it to the venous system. That's why we get our systemic symptoms like edema, your fluid overload, so your bounding pulses. So all of this type of stuff where you have that backflow into the systemic system. And so if you think of it as a continuous circuit, you can see why, as soon as one area doesn't work, how it causes problems behind it, behind it, behind it, behind it. Does that make sense?
Yes, it does. You painted a picture.
Absolutely.
All
Absolutely.
right. So that's
Thanks,
kind of how I
Brandy.
think about it. Yeah. What'd you say, Jess?
Oh, I said thank you.
Oh, yeah, no
She
problem.
made a really good point too, that when left-sided lung failure goes untreated, or say your patient is not compliant with their medications, or like, oh, I don't want to take my diuretic because I need to go to the mall and I don't want to have to pee all day, right? And they're not compliant, then when they become symptomatic, that fluid backs up into the lungs, then they don't do anything about it again. And then that that backup just keeps going and going and going until it goes all the way back to the right side of the heart, causing those other symptoms. So you're like, hey, Jess, but my patient was admitted for his left-sided CHF exacerbation, and he put on 30 pounds of fluid, and he has significant peripheral +4 edema in his lower extremities. But it said it's left-sided, and it said it's in his lungs. Okay. But that is because that left-sided heart failure went untreated for a significant period of time, that it kept backing up, backing up, backing up until it affected his peripheral, which is caused by right-sided failure. Does that make sense? Your left would be your lung, and then the right side would be your whole body, right? Right. So left lung, right rest of body, and we're gonna get there. This is a clinical snapshot of cardiogenic edema. This patient profile is on Mr. Jones. He's a 69-year-old male with a history of hypertension and CAD, presenting with fatigue and shortness of breath. Your patient has pre-existing coronary artery disease, hypertension, or I don't know why it says or heart failure. I should say and heart failure. The physical exam is jugular venous distension, JVD, bilateral crackles, S3 heart sounds, and tachycardia. So this shows cardiomegaly, which is an enlarged heart and bilateral pulmonary edema. So is this patient right or left-sided heart failure?
Right.
Why?
But see,
The
that's a lot of
JVD.
systemic issues.
Yeah. JVD bilateral.
I thought left.
Let's say left because the right would be your peripheral edema. The left, getting left lung.
I thought JVD only was in the right-sided.
So remember what we just talked about. So if Mr. Jones has left-sided heart failure, which is causing bilateral crackles, cardiomegaly, which is enlargement of the heart because the heart is working so hard, and it's exacerbated to the point where it's then caused right-sided heart failure, which is then causing symptoms of not only left with bilateral crackles, but also right with JVD, heart, S3 heart sounds, and tachycardia. So there's just a
The other clue here, guys. Oh, go ahead. Sorry, Jess.
No, go ahead. You're fine.
The other clue here is the fact that he has a history of hypertension. So when you think about the heart, it's a muscle. And there's two types of muscles. We have the muscle that's like somebody who does yoga every day, right? They're very strong, but their muscles are lean and they stretch. They're very limber. Then you have the type of muscle of somebody who lifts weights, right? Again, strong, but that muscle is big and bulky. And so when we have, our heart should be like a yoga, somebody who does yoga every day. We want our heart muscle to be lean and limber. But when we have untreated hypertension or hypertension and somebody isn't compliant, that heart, the left side of the heart's having to lift weights. It's having to push really, really hard to get the blood out because of the resistance. And so when that happens over time, that muscle now becomes your weightlifter muscle. It's big, it's bulky, and that's how you end up with this cardiomegaly on your x-rays.
Which can also be referred to, depending on what side we're talking about, in this situation, left ventricular hypertrophy.
So is it left or right?
This patient has left-sided heart failure that has now caused failure of the right side, which is causing right-sided symptoms, right and left, because we're seeing both.
So they got both.
We're seeing both. But what did it start with?
Left.
Is left. Yes.
Back up to the right.
Because it's backing up, right? Good job. Oh, and BNP. This is your B-type natriuretic, I don't like that word, peptide. Okay, don't get it confused with BMP, which is your basic metabolic panel, right? This is a BNP, okay? So this lab is a biomarker for pulmonary edema and is used to diagnose CHF sometimes, and is also used to evaluate if your patient is having an exacerbation of CHF. Okay, so the higher the number indicates the level of heart failure. So we usually said a BNP that is greater than 500 is bad. Okay, so less than 100 is normal. That's all of us. If we don't have heart failure, we have normal functioning hearts. Okay, 300 plus is mild, 600 plus is moderate, and 900 plus is severe. I have seen a BNP, and Brandy, I would love to know the highest BNP you ever saw. The highest BNP that I have ever seen was 70,000. And we're talking of 100 to 900. This patient was 70,000. He was literally carrying 40 pounds of fluid. I am not exaggerating at all. Brandy, what is the highest BNP you've ever seen?
You have me beat. I think in the 50,000s.
You do, yeah.
So
it's probably OBN stuff. But, girl, I don't know. She just texted me and said to send you. And then she said, please. And she said, please. I don't know. Sorry, I'm so sorry there's interrupt. This is OBN week, guys, remember. So we're trying to get all of our ducks in a row for OBN coming. It's gotta be.
I'm sorry, can I just
Yeah.
ask a clarifying question real quick to either you or Miss
Sure.
Brandy, one of the two? I just want to make sure I got this right. The reason why it was left-sided, what you're triggered was because they had a history of the hypertension, and it was because of the cardiomegaly.
The
Yeah,
bilateral
and they
crackle,
had lung symptoms.
Yeah, crackles.
crackles in the lungs.
Yeah.
Okay, I just wanted to make sure that, like, if I had this patient, like, it jumps out at me. So it was the crackles
Yes.
and the cardiomegaly and the hypertension, all three together, that kind of threw that into the left side.
Because
Yes.
and that's a good question, Amy, because think too, you can have that overworked muscle on either side. You can have left ventricular hypertrophy, but you can also have right ventricular hypertrophy. So when you have right-sided heart failure, it's that right ventricle is working so hard. Okay. You have all of this fluid in your body, right? You have all of this extra fluid. That extra fluid that's in your circulation, the very first place it's going to go is that right atrium, right? When that right atrium contracts, it's then going into the right ventricle. If you're having right-sided heart failure, it's that right side that is feeling this huge amount of workload. The workload is so heavy that that right ventricle has to work so hard to push it into the pulmonary artery, into the lungs to be able to get oxygenated and then go to the left side to go to the periphery of the body. Okay? But then let's go to the other side. When you have left-sided heart failure, that means that you have your aortic valve, and right before your aortic valve is your left ventricle. I want you to think about, we've always been taught, if you are in a car that gets submerged in water, the first thing you're supposed to do is roll your window down, right? Remember when we used to roll our windows down or press the button down? Because when your car is submerged in water, guess what you can't do?
Open the door.
You can't open the door, okay? Because on the other side of the door is this immense pressure, okay? So when our left ventricle pumps blood out of that left ventricle to the periphery of the body, past the aortic valve, it has to have enough pressure to be able to push against the resistance on the other side of the door. Okay, does that make sense? Right? So the harder that left side has to work, the bigger and more hypertrophied it gets, leading to more failure. Does that make sense?
Yeah.
Okay. So the higher that pressure is on the outside, which is what we call afterload, we're going to get there, okay, is the harder that the left ventricle has to work to get the blood out to the periphery. Okay. And the blood inside that's going out before the door, in front of the door, in the car, that's your preload. Words I need you to know.
I remember that part.
Yeah. Does that make sense, guys? Okay.
Yes, thank
Good questions. Very good question. Okay. This is talking about non-cardiogenic edema. So the leaky barrier and a breach in defense. So this is when those capillary beds are not keeping the fluid inside. Remember, and I've told you about this and I've drawn you pictures of it. Now, I don't know if you guys have ever seen it because I didn't have some of you in advanced farm. Remember the hot dog links that line the vessels?
You went over that.
I did go over it again, the proteins.
Yeah.
So you see these guys? See these little cells here? Or can you guys see what I'm pointing at? The little cells that are lining this top healthy capillary. Okay. These are amino acids. These are healthy protein albumins. Okay. And they line all of our vessels. They keep everything inside. This is like the inside of the hose. Okay. When we have a decrease in albumin, our patient is very sick. They're not getting the nutrition that they need. They're malnourished. They're infected. There's something wrong with them. Okay. This can cause damage to this barrier, this natural barrier that we have inside the hose. Okay. When that happens, that's when we get an increase in permeability. Permeability meaning that things can cross it easily. We don't want this to be very permeable. We don't want everything to be able to get in and out, in and out. This is not a revolving door, right? You better have a key and knock on the door for me to let you in.
You said when they have a decrease in albumin.
So this is when you have an injury to this capillary, to these vessels, where you have, see these breaks? When we're looking at the leaky capillary, you see the break in between those cells. That is how the fluid seeps out. And this is what we call third spacing, where it's not going into the circulatory system. It's not in the lymphatic system. Those are the only two circulations we got. It's going into the other third space outside of those circulations. Go ahead, Lisa.
I just wanted to know, Jackie was saying something, I felt like I missed it.
Yeah,
About the pre-albumin.
Yes, we were talking about, remember when, and Tonasia said I did go over it last term. We were talking about the little hot dog links that lined our vessels.
Mm-hmm.
That is a really good depiction of what we have here. And these are made up of albumin and proteins.
Okay.
And when we have a break in those albumins, those little hot dogs, is when we have fluid that leaks out.
Okay.
Yep.
I just wanted to make sure.
Oh, absolutely. So, this has caused damage to the pulmonary capillaries or alveoli. A direct or indirect lung injury triggers a massive inflammatory response. See, it says inflamed. Okay. This inflammation makes the capillary walls more permeable or leaky. Protein-rich fluid, which normally stays within the vessels, escapes into the interstitial space and alveoli and into that third space where it's not supposed to be. So your primary causes and often leading to ARDS, we are going to talk about ARDS extensively next week. This is acute respiratory distress syndrome. Believe me, you're going to be sick of hearing it next week. ARDS, sepsis, pneumonia, which is a direct lung infection, right? Pneumonia is within the lungs, major trauma, and inhalation of toxins, because that can cause injury to the surrounding tissues, right? So this is non-cardiogenic pulmonary edema. So this is a clinical snapshot of non-cardiogenic edema. This patient with a recent history of a major systemic insult, such as a severe infection or trauma. Our physical exam, we have signs of systemic inflammation. We have fever, hypotension, labored breathing, forced crackles. This x-ray shows diffuse bilateral infiltrates. See all the white in the x-ray? White all over a lung x-ray is bad. Especially when it's all over, we call that a white out. Okay. The more white you see, we call that infiltrates. That is congestion. That is fluid. Okay. And you do not see the cardiomegaly. So that is a key difference between cardiogenic and non-cardiogenic edema. There is no cardiomegaly. The heart is not enlarged because it's not being caused by heart failure.
COVID caused really bad pulmonary edema, non-cardiogenic pulmonary edema. It was
severe ARDS.
Yeah.
It's horrible. So this is talking about the BNP again. In non-cardiogenic, your BNP is normal or only mildly elevated. So you're not seeing 900, 1,000, 35,000, 70,000. You're not seeing any of those numbers. Okay. I really like this because it puts it side by side with the differences between the two cardiogenic and non-cardiogenic. Do you want me to go through this?
Yeah.
We didn't talk about ejection fraction, but I think that's coming next. No, it is coming though. Any questions on this? The differences? Good. Okay, uncovering the why is key. So we use a BNP for diagnostics, the single most useful test to differentiate between cardiogenic and non-cardiogenic, and also the severity or exacerbation of the heart failure if it is heart failure. A chest x-ray is to visualize the heart silhouette to see if you have cardiomegaly and also see what's happening within the lungs. Is there fluid? Where is it? Is it on one side? Is it in the bases? Is it covering the entire lung? Is it only in the right side? Is it only in the left side? Okay, these things are important. An echocardiogram, this is an ultrasound of the heart used to directly assess the function, measure the ejection fraction, and identify valvular disease or wall motion abnormalities. Ejection fraction is the function of your left ventricle. Okay, you want your EF to be greater than, and Brandy, correct me if I'm wrong, you want your EF to be greater than 55%. I think
50 to 55.
50 to 55 is normal. Anything
Yeah,
more, I mean, that's great. The higher the number, the better when it comes to an EF.
It will never be 100 though.
Okay. And then you have a pulmonary artery catheter. This is only either in surgery or in the ICU, most likely a cardiovascular ICU. This is an
And
invasive
even in
tool that
cardio, even they don't use swans that much anymore. It's rare.
Really?
Even in cardiac ICU, they don't use swans very much anymore.
Listen, you start talking about a swan and I'm leaving. I was a medical ICU nurse, lungs, kidneys, all of the above. You start getting into like real CVICU, like
Well,
that makes me just a little nervous.
We used to do it all the time. I mean, like we used to do it all the time. And we would do wedge pressures per shift and all of that. And they just don't do it very much anymore.
It's called a Swan Gans, like GANC catheter.
Oh.
Actually, Brandy, you can probably answer this a lot better than I can. Can you explain the CVP?
Yeah. So, actually you can get a CVP off of a normal central line catheter.
Yeah.
And it doesn't have to be a Swan Gans. Yep. And so what this is measuring is the patient's fluid status. So we're looking to see, is our patient basically, do they have the appropriate fluid levels, or are they getting a little dry and we need to get that fluid up, or third spacing, or are they too wet and we need to get some of that fluid off of them. And so it's a waveform. It's on your monitor. It's not a continuous thing. To do a central venous pressure, you have to have the patient, so you have to level your line. It's kind of like an arterial line. It's set up very similar to an art line. If you've seen what an art line looks like, the setup is exactly the same. And so
I'm going to
you have,
interrupt you for a second, Brandy.
Yeah.
Remember when we were talking about the EVP, the external ventricular drain for the brain? Remember we said it had to be leveled at the tragus? So when we're talking about these things, when she's talking about leveling, we're talking about the same exact thing, except it's at a different level.
Okay.
So you
Yes.
want this
It's
level to be level with the patient,
yeah.
with the mid-axillary line
Yeah.
of the patient. So when you're talking about an arterial line where it gives you a constant blood pressure, when you're talking about a CVP, that leveler is everything. It is extremely important, just like when we were talking about the EVP for the brain. Sorry,
Correct.
Brandy, I just wanted to
No.
make that connection for the.
Yeah, no, you're fine because it's true. If you don't level correctly or frequent, I mean, honestly and truly, one, most ICU nurses know what their waveforms are supposed to look like. Like we can look at a waveform, even if it wasn't labeled, I can tell you if you're a CVP, I can tell you if you're in the right ventricle, I can tell you if you're in the lung, I can tell you if you're in an artery, like based on the actual waveform itself, you know what you're looking at. But that those numbers could be false if you don't appropriately level your equipment on a routine basis, at least every shift. Anytime you reposition your patient. So let's say that on nights, because in ICU, you don't have an aide. It is you. Okay, you do all care. This is why it drives me nuts when nursing students say something about doing aid work. No, it's all nursing work. Okay, it's all nursing work. So let's say I bathed my patient and got him, fluffed and puffed, as we used to say, right? And then when I'm done with that, I really need to level my lines again. So if I have an art line, I need to be leveling that art line before I really use those measurements. I should be leveling my CVP before I get a measurement. But it is looking at that central venous pressure. So typically that is going to be in your superior vena cava. That's where we take a CVP. And so you want that number. And so it just tells you about your patient's fluid volume status is what it's really looking at to let you know if your patient's a little dry, if your patient's a little wet, if it's just right. But the doctors will use that a lot to determine, do we need to diurese this patient? Do we need to give them a little bolus? Although I'll tell you, as we talked about, your non-cardiogenic causes of pulmonary edema, if you're in the ICU, you probably have one of those non-cardiogenic causes of pulmonary edema. And this is why it's really important that before we give fluids, we know where our patient is sitting. Because if they're already a little fluid overloaded and we add more fluids, there is a very good chance we're going to put them in pulmonary edema.
Is anybody in the book online?
What did you need?
I was looking for the CVP because I know somebody's going to ask me what the normal level is.
It's like 12 to 20-ish.
I don't
know what
remember.
the book. Yeah,
I haven't
I
done
don't
a
know what the book
CVP in
says.
5 years. Was somebody looking it up?
Yeah.
Okay, thank you.
One of us will get it.
4 to 12? 4 to 12 centimeters of water? Okay, so I was off. 4 to 12. Yeah, that's what AI says.
I am not going to ask you what a normal CVP is, just to be clear. But it is good for you to know, at least, this is a good to know. This is good to put in your filing cabinet of what a normal CVP is, especially when we go into our ICU rotation, if we're lucky enough to see one. I want you to be able to, oh, that's 27, that's high. Okay, go ahead, Lisa.
The ejection fraction is how well the ventricle is working.
Yes.
Okay, I just want to make sure I had that.
Go ahead, Brandy.
No, that's fine. Your ejection fraction is the actual amount of blood that the left ventricle pushes out in one contraction. So if you have 100 mLs in that left ventricle when it's at the very end of diastole, when it's the most relaxed, if you have 100 mLs and when that ventricle contracts, it pushes out 60 mLs and leaves 40 in, your EF is 60%.
So the amount of
That's a good way to put it. It's the actual amount of blood that's pushed out of the left ventricle during contraction.
okay.
During
I've
systole.
never heard it like that. That's good. That's a really good way to put it. No, that's the EF. That's the ejection fraction.
That's the EF, yeah, injection fraction. So,
Can you say that one more time?
but, so the way I explain it, if your ventricle fills, your left ventricle fills to 100 mLs of blood when it's at its most relaxed, and then when it contracts, it pushes out 60 mLs and leaves 40 mLs in that ventricle, then your EF is 60%. You got rid of 60% of the blood in one contraction.
Okay, thank you.
Yeah, absolutely. So I was going to tell you guys a story about why it's really, really important if you are in critical care that you understand what your waveforms are and what they're supposed to look like. When I worked in the electronic ICU, we live monitored every patient in every ICU in that system. And so we could see their waveforms, we could see their monitor, we could camera in and see the patient. And so we were like a second set of eyes. And we had a nurse who called us. It was actually one of the other people I was working with, but who had that unit. And the nurse said, I can't figure out, the doc wants a CVP and I can't figure out how to get this. I can't get the number. It doesn't make sense. And we're like, okay. So the person I was working with started to walk her through how to level it where it needed to be. The patient needed to be flat, how to do that whole process. So the nurse levels everything. This was an internal jugular and IJ. So it was in the internal jugular, or it was supposed to be in the internal jugular.
Oh.
When the nurse opened up the level and the waveform came up, and she had done this a couple of times, she didn't recognize what we recognized right away, which was as soon as that waveform came up, the person I was working with went, oh, blankety blank, Brandy, get over here. And I walked over and I went, oh no, because what we both recognized right away was that catheter was in the carotid artery. It was not a CVP. It was an arterial waveform. And so they had been infusing into this catheter for days.
No.
Yeah.
Never.
And so
never,
again, this is why it's really important that you know what you're looking at, what you're doing, what you're supposed to be seeing. Because again, both of us recognized immediately that was not a CVP waveform, that was an arterial waveform, which meant
you never use any medications through an artery, ever, unless you are in probably in cardiac surgery. I don't even know.
I don't even know. I don't think they even do it in OR. I've never heard of.
Never in a million years. I don't care how desperate you are. On page 437.
So what if they have and I've heard, like I said, I've never had to do those type of things like that. The knowledge I have is pretty basic. But I follow my little TikTokers and I follow them. And most of them say that like under certain circumstances, things can be infused in the arts. Heard people that work in like NICU say that they put stuff through the art line in their babies. And so, I mean, I know for this purpose here,
So
And I knew that nothing could go through an artery with my basic knowledge, but I'm just saying it's just you have all of these people that say these things that
the only thing that made a difference with your statement right there was when you said NICU, because that's a whole different world.
Yeah, as I
Whole
say,
different world.
that,
I know
once you say
nothing
NICU,
about the
that is, it's a whole
but
different world. But in adults, no. But my other thing that I want you guys to think about and why this is so important is that if that nobody had recognized, if we had not recognized that this patient's line was in their carotid artery, by the way, that patient had to be transferred to a level 1 trauma center and had to go to OR to have that catheter removed. It was not a small thing at all. But think about the fact that if nobody had been paying attention and they pulled that line thinking they were pulling a central venous line and then just held some pressure for a little while, that patient could have easily bled out, like easily bled out.
oh, that's so scary.
Yeah.
Okay, I want you to look at page 437 in your Hunin, however you say it, book. And this shows you CVP monitoring. The book actually says a normal CVP is 2 to 8. That's what the book says.
Okay.
A CVP of greater than 8 indicates hypervolemia, which is excessive fluid circulating in the body, or right-sided heart failure. On the contrary, if a CVP of less than 2 indicates reduction in preload or hypovolemia. Complications of a CVP, which are the same for a complication for a central line, would be infection, pneumothorax, or an air embolism. And this shows you, especially on the next page, it shows you the leveling of the arterial line. So are you looking at this page? Anybody? No, you're not looking at it. Okay. So on the page, there's a little monitor. You see the little monitor?
Yeah.
Do you see that second line where it's going like this?
Yeah.
That is an arterial waveform. That second line. Because every time that heart beats, the waveform, it goes up. Every time. Okay. That is what an arterial waveform looks like. Okay. On that monitor, and then the ECG is obviously the heart rate. And do you see how it goes in rhythm with that first and second line? It's that arterial line going up is right after that heartbeat because they're in sync with each other. Okay, because they're both reacting to that heart rate. On the next page, it does talk about intra-arterial blood pressure monitoring, which is an arterial line. And it talks about it's called the phlebostatic axis, which we were saying the mid-axillary line. I mean, it's basically the same thing, but the phlebostatic axis is the reference point for the atrium when the patient is in a supine position. It is the intersection of 2 lines on the left chest wall. It's the mid-axillary line between the anterior and posterior of the chest. Okay, so it's like right here. Phlebostatic axis. Okay. My last question on my NCLEX was, and I'll never forget it. And I must have got it right because my test turned off and I passed. So I must have gotten it right. But my last question on my NCLEX was a priority question about like putting the things in order about how to do an Allen's test. Okay. And the Allen test is used to assess for adequate perfusion of the hand via the ulnar artery prior to cannulating the radial artery for pressure monitoring. So let me see your hand. So when you do an Allen's test, you cut off circulation on both the radial and ulnar artery. The hand is going to pale up. And then when you release one, the hand goes pink again. And it shows you that there's good circulation to that hand via whichever artery that you unoccluded. Okay, so I just took her hand and I put my fingers on this side and I put my other fingers on this side and I occluded this radial artery and the ulnar artery at the same time. So I literally stopped blood flow to her hand. What's going to happen is that hand is going to turn pale. Okay. When you take, say you want to test the radial artery, you're going to let go of the radial artery while you're still compressing the ulnar, and you're going to see blood flow restore to that hand. That means that you have good radial artery blood flow. Okay, this is called the Allen test.
That's all.
She said, do mine. Now, I don't, so yes, because the palms of people that have, people of color are,
Well, I don't think I'm doing it right because today,
Do it harder.
today's hands are not losing any color. And I
do you feel pulses under each sides of your fingers?
You can feel it because when she had mine, it just felt like my.
I wish you guys had somebody next to you so you could do it on each other. You should do it on each other.
Maybe, okay, try mine, because listen.
Now they're all turning each other's pulses on.
Right.
So it's important. I never thought in a million years that I was ever going to be tested on the Allen test during my NCLEX. Never in a million years did I think that that question was going to pop up, and it sure did. Girlfriend, I don't even remember, because I swear to God, one of them said to raise the arm in the air, and I don't know if that was first or last. I can't remember if it was first or last, and I'll tell you what. Let's see. Okay. The Allen test is performed by compressing the radial and ulnar arteries simultaneously and asking the patient to make a fist, which is what it said on my NCLEX. I remember the fist, which causes the hand to blanch, which means make it pale. Okay. After the patient opens the fist, so you compress the arteries, you make a fist, and then you open the fist. Well, hold on, I'm telling you. 438. You ask the patient to make a fist. That causes the hand to blanch. After the patient opens the fist, the nurse releases the pressure on the ulnar artery while maintaining pressure on the radial artery. The patient's hand will turn pink within 3 to 5 seconds if the ulnar artery is patent. NCLEX. Couldn't believe it. I told you I must have got it right. So I'm just saying. All right. Who needs a break? Let's go. 10 minutes. No more, no less.
But that's gonna be.
All right.
Into May.
Are we ready? Has it been 10 minutes? I feel like it has. Sharia said yes. I believe her. She's always honest with me.
always late with time.
I'm chronically, well, you guys know I'm always late.
Don't be. Your speaker on.
Oh yeah, that Miss Sharia, she don't lie. She don't play.
My mom,
She's always front and center for me, girl.
when we have events, my mom said, we're not running on Cephas time. I'm telling you a half hour before we have to be somewhere.
Yeah.
Because you guys were always late.
Will you close the door?
We were late to my wedding.
We were almost late to my wedding.
That's okay. It was yours.
Right?
I'm telling you,
It is.
it's fine.
I think that there is great. What is the word that I'm looking for?
Okay.
There's a word that I'm looking for, but I can't get it. But being fashionably late makes this a great thing.
The smartest people are.
Yeah.
All right, let's get started. Okay, so this slide, it says the treatment must match the origin. So while all patients require oxygen support, the primary interventions diverge completely based on the underlying cause. Simply treating the fluid in the lungs without addressing the root cause will fail. It's not going to do anything. It's a temporary Band-Aid fix. So strategy one is that you fix the pump by decreasing the cardiac pressure and offload the fluid. So not only are you decreasing the cardiac pressure that it has to fight against, you're decreasing the amount of fluid so that it's easier for the heart to relax and not work as hard. That is for cardiogenic. Because remember, cardiogenic is that there's something wrong with the pump.
Oh, okay. I understand because it's two. Strategy one is fix the pump, so that's going to be for your cardiogenic. And then
Yes.
strategy two is going to be for your non.
Yes. So strategy two is non-cardiogenic. So this is to heal the lungs and treat the injury, provide respiratory support.
So I have a question.
Go ahead.
So in one of these situations, would a chest tube provide rest for the lungs?
No.
To heal. So what's that
No,
is
they
to
heal.
reinflate the lungs.
We will get all up into
Well,
chest tubes.
This I was trying to
No, it's a good question. Because
get the gears turning in my head.
yes, because what I want you to realize is that this is happening inside the lungs. A chest tube is outside of the lung. It's in that pleural space, but it
it's
never
not the
goes
lungs.
into the lung itself. Yeah, that's a good question. Okay. Treating cardiogenic edema, decreasing pressure on the heart. Your goal is to reduce the preload, right? The fluid inside the car. I really like the car underwater analogy. Does that work for you guys?
Never heard of.
But does it make sense? You weren't here. Okay. When we're talking about preload and afterload is the pressure, the resistance that you have outside of the aortic valve for the left ventricle to pump against. So if you're in a car underwater and you're trying to open the door, the afterload is the water on the other side. You can't get that door open.
Right.
It's too high.
Okay.
Okay. So the preload is what's in the car.
Okay.
Okay. So the car door, that's the aortic valve. Your
And then
car
the
door
afterload
is the
fluid
aortic
on the
valve.
outside.
The afterload is outside the door. What's beyond the aortic valve, which is your periphery, right? It's the rest of your body.
Okay.
Okay, that makes sense? So you want to reduce the preload. So what's in the car, the amount of blood, right? What's in that left ventricle, the amount of blood in the left ventricle. We want to reduce the afterload, which is the pressure on the other side of the door, the other side of the aortic valve. That's the pressure I have to fight against. I want to reduce that. And I want to improve contractility. I want to make the heart work effectively. Every contraction, I want it to be at its best. Can you close those blinds? It's really bothering me. I love you. Thanks. So, oh, that's so much better. All right. So in order to do that, we have diuretics, which is most likely going to be, especially in a CHF exacerbation, we're talking about loop diuretics because they are the most effective diuretic. Furosemide, aka Lasix. What is my other one? That's a loop diuretic.
Bumex.
Bumex, aka
I can't think of the name.
Bumetadine. Bumetadine. Okay. So diuretics, this is the cornerstone of treatment to offload the excess fluid and reduce the preload. So I want to take away fluid. I want to make it easier by reducing the amount of fluid being pumped out. Okay. Vasodilators like nitroglycerin, this is to open up the vessels, which reduces both the preload and the afterload, and it lessens the heart's workload overall. I will say vasodilators are not like that first step in treatment, I will say, but can be used for this reason. Positive inotropes like digoxin or dobutamine, this improves contractility. Okay, this is to improve the heart's pumping strength, which is that contractility. And then positioning, you want your patient in a high Fowler's position to help ease breathing. Sitting up is always going to be a better position to breathe than laying down, especially with a patient that has significant pulmonary edema. Okay. Treating non-cardiogenic edema, which is supporting the lungs. So we want to treat the underlying injury. We said that could happen from ARDS, sepsis, chest injury. We want to provide supportive care and implement lung protective strategies. So treat the root cause, administer antibiotics for sepsis or pneumonia, manage the source of trauma. What caused the non-cardiogenic edema, and that's how we fix it. Mechanical ventilation, especially when it comes to ARDS. The goal is to use lung protective strategies such as low tidal volumes and appropriate positive end expiratory pressure, which is what we call PEEP. We will talk about this a lot next week. PEEP. Don't get ahead of yourselves because we're on cardiac. We're not talking about ventilation just yet. Okay. Conservative fluid management. This is crucial to avoid fluid overload. They're already overloaded. They don't need more. We just need it in the right places. Okay. This can worsen the capillary leak and pulmonary edema. Remember those sausage or those hot dog links? Remember those leaks in the capillaries? The more fluid you have, the more it's going to leak. Okay. The more it pushes those hot dogs apart. Hot dogs. And then we also can have prone positioning. This was very, very popular in our COVID days and was really one of the only reasons our patients with severe ARDS, if they survived because they were able to adequately oxygenate by prone positioning. And we'll talk about that next week too. And this is placing the patient on their stomach so they can redistribute perfusion and improve ventilation perfusion, which is also called BQ matching, and significantly improve oxygenation in severe ARDS. So 2 paths, 2 plans. Your key takeaways, you have pulmonary edema, which is fluid in the lungs caused by either a pressure problem or a permeability problem, so cardiogenic versus non. A patient's clinical history and BNP level are the fastest and most effective clues to differentiate what is happening. Is it CHF or is it something else? Okay. Cardiogenic treatment focuses on the heart with diuretics, vasodilators, and inotropes. And then non-cardiogenic treatment focuses on the lungs, treating the underlying cause, lung protective ventilation, and supportive care. When fluid becomes the enemy. So this, we've already talked very extensively about pulmonary edema. But this is just comparing when the fluid is in a different place, it can cause a whole lot of other problems. Okay. So this also talks about that impending doom, anxiety, and severe shortness of breath. This is flash pulmonary edema. I want you to write flash pulmonary edema, where it says that key symptom of impending doom. Because not all pulmonary edema is going to come with that. There are different levels of congestion when we talk about fluid in the lungs. This, on this side, very important, this is called cardiac tamponade, okay? Around every organ system, we have a sac, right? We have the pleural sac, which is around our lungs. We have the peritoneal sac, which is surrounds our digestive organs. With the heart, we have what's called the pericardium, the pericardial sac, okay? I want you to think of that, and we've talked about this before, is that it's like a Ziploc bag, okay? There are two sides of the sac. There always is, no matter what. And every organ sac, there's going to be, I hate the word sac, but it's just the way it's going to be. It's like a Ziploc bag. When that Ziploc bag rubs together, because we move, our bodies move, right? That can cause friction. So what do we need to alleviate friction? A lubricant. Exactly. So it's normal to have a small amount of fluid within the Ziploc bag, within that sac, the pericardial sac, okay? That is normal. What's not normal is when that space fills with fluid, okay? And what do you think would happen if we filled the sac surrounding the heart with fluid and put pressure on the heart?
It would constriction.
It's going to stop.
Yeah.
Eventually, the heart is going to stop. It's called strangulation. Okay. So this is increased pressure on the heart from fluid accumulation, which prevents it from pumping efficiently. This is a medical emergency. This is extremely serious. Okay. You have Beck's triad. I need you to know this, that this patient is going to be hypotensive. We have JVD. This is key. Muffled heart sounds. Why?
It's because of fluid.
Because it's covered in water. Water, blood, whatever, fluid. It's literally pumping underwater. So if you think about you're underwater and you scream, it's muffled, right? You're talking underwater, it's muffled. When your heart's underwater, the sounds are muffled. Okay? So, Beck's triad, hypotension, JVD, muffled heart sounds. Risk factors, we have severe asthma, hypertension, including preeclampsia, diabetes, obesity, CHD. I feel like that should say CHA.
Yeah, chest of heart disease.
That is a typo. That should say CH. And central nervous system injury. This patient is going to be short of breath and possibly wheezing, especially when laying flat. And there is definitely going to be a sense of impending doom. Definitely. Your treatment is to, there's a lot of typos on here. Reduce the preload with nitrates by vasodilating, diuretics, and morphine. Remember, we talked about morphine, how it also causes vasodilation and decreases the oxygen demand. Okay. We also want to reduce our afterload by lowering the blood pressure, which is why it lists ACE inhibitors. Okay. A nursing intervention could be a CPAP to facilitate ventilation. Okay. Monitoring vital signs, oxygenation, and patient assessment. What truly needs to happen is what's called a pericardial window. Okay. And this is when they literally put a needle inside that sac and drain the fluid off. The fluid has to be relieved for the heart to pump effectively.
And you said it's called a pericardial
A
window.
pericardial window. So this is just a nice little picture that shows you a normal pericardium versus a pericardial effusion. A pericardial effusion is fluid buildup. It is a precursor to cardiac tamponade. Can you have a pericardial effusion without tamponade?
Yes.
Yes. Yes. Okay. Just because you have fluid buildup doesn't mean it's going to get to the point of tamponade. But the goal is to prevent tamponade, right? So this can progress to circulatory shock and cardiac arrest if this fluid continues to build up and puts pressure on the heart and will cause it to stop beating. Okay. Pericardial fluid builds up slowly over time. It allows the pericardium to stretch out to accommodate bigger volumes of fluid without compressing the heart. So this is more of a chronic pericardial fluid buildup. Okay. Then you have Beck's triad down here, which we discussed. This is hypotension, JBD, and muffled heart sounds. This is the classic Beck's triad for cardiac tamponade. Acute pericardial tamponade or cardiac tamponade. This is sudden fluid accumulation. There is no time for adjustment like there was up here. There is no time. There is a dramatic increase in pressure inside the pericardial sac. This can be caused by chest trauma, a ruptured aorta, ruptured of ventricle after a heart attack. This is super serious. This is a huge medical emergency and has to be treated as soon as possible. Okay. So, this is a medical emergency where fluid accumulation in the pericardial space puts extreme pressure on the heart, preventing it from pumping. So you see the difference between a healthy heart and the fluid buildup around the heart. There's not much space for that fluid. So if this is happening, and especially if it's happening acutely, this can be devastating very quickly. So, the pericardial window can also be referred to as a pericardiocentesis, just like when we talk about a thoracentesis or a peritoneal or amniocentesis is amniotic fluid, but it's the same idea. It's fluid removal, right? It's fluid removal from a sac specifically. And then we talk about Beck's triad again. It is important that you know Beck's triad. So this can be caused by pericarditis, a pericardial effusion that gets out of hand, cardiac surgery or trauma, a recent MI, cancer within the heart or around. Symptoms are going to include dyspnea, which is shortness of breath, fatigue, angina, tachycardia, and tachypnea. Remember, this is going to severely reduce your cardiac output, right? So this patient is going to be very symptomatic, very short of breath, very fatigued. They are not oxygenating well at all, okay? The more fluid buildup they have, the less cardiac output they are going to have, the less oxygenation to the tissues and the brain they're going to have. So the treatment is going to be a pericardiocentesis. This is the number one treatment. You have to alleviate the pressure. If you are watching Grey's Anatomy like I am right now, Ross, crazy dude. He's a crazy resident.
Should I plug my ears? I'm not.
I'm in like season 5.
Okay.
Maybe more, maybe season 7. I don't even know.
I cannot think back that.
I don't know,
So
but that
wait a
dude is
minute.
crazy.
You restarted, then I already know.
And he did a pericardiocentesis in the ED blind. He stuck a needle in some dude's chest
Yes.
without an ultrasound.
Just-
Because he was, he went cuckoo cut
But
nuts
then did it
bananas.
save stuff?
It did save his life.
Yeah.
But then he ended up killing someone, like the
Yeah,
next episode.
it
so.
was.
You don't do this all willy-nilly. Okay. This is done under ultrasound by a qualified surgeon. Okay. So treat the underlying cause, but the main goal priority is that you have to alleviate the pressure. You can treat the underlying cause after you save their life. Okay. So remember, there are times where the goal is you have to treat the underlying cause, right? When you see the word severe, when you see the words medical emergency, we must act now. Alleviate what is causing the patient to die, then treat the underlying cause. Do you see the difference? Good question.
So, is this something that is going to reoccur for this patient, or is it?
That's a great question.
Some of the
I think it would depend on the cause. She asked if this is something that could be a chronic thing where it could reoccur. And my answer is absolutely, and it depends on the cause. So say this patient has cancer and it was caused by the cancer. If you don't remove the cancer or you don't remove the underlying cause, then it's absolutely can recur again. Absolutely. So anything, because it's happening from an underlying cause, if you don't fix it, it's going to recur. Yeah, good question. Hemodynamic support, we want to have fluids unless the patient is hypervolemic, obviously. Volume expanders, that's, I don't understand why she would put both. It's the same thing. Volume expansion and fluid. Yeah, I mean, that's the same thing. Volume expansion and fluid is the same thing. This is why I wanted to add my own stuff. Vasopressors, these are your, I refer to these as pressors, but they're the long word, vasopressors. This is what causes your blood pressure to go up when you are severely hypotensive. We have 4 drugs. And I really hope that we all get the chance to see these in action when we go to the ICU. You have your norepinephrine, which is Levophed. You have neosynephrine. You have vasopressin, and you have epinephrine. Those are your 4 vasopressors. Also, there is a paper that I put on Brightspace. It's a list of common medications. It is blank. The medication is there, and it would be in your best interest to fill it out. It is your most common critical care medications, and it's on Brightspace. You should do that. And then dobutamine, we talked about this. This is an inotrope. This helps with contractility of the heart. Okay. And then your nursing interventions is, of course, we're going to monitor our vital signs, EKG, lung sounds, labs, and then supplemental oxygen, bed rest. You want the head of the bed up, greater than 30 degrees. And then you want to educate that this is a complication of a pericardial effusion. This is very serious. If you don't treat the underlying cause, this can happen again. And hopefully it doesn't. Brandy is going to cover CHF in the morning on Wednesday, and do like a whole little lecture on CHF. So I'm going to kind of skip over this. I'm going to let her do that because we talked about pulmonary edema a lot today. I will just say we talked about the EF. I knew this was coming, that gauge thing. Gauging the damage key performance indicator. So this is talking about the BNP. This is your biomarker released by the ventricles when they're stretched by excessive pressure. This shows you the level of heart failure. Okay. Normal is less than 100. It said that on the other slide. Normal is less than 100. I think it said mild was 300. Greater than 600 was moderate, and greater than 900 was severe. And then this talks about the EF. This is the ejection fraction, is the amount of blood ejected from the left ventricle in one pump, and it's measured by an echocardiogram. Normal, 55 to 70%. Less than 40 is bad. Bad. I'm gonna let her. Cardiomyopathy. Sorry, let me let you catch up. Because I did just skip like 4 slides.
I'm like, I got lost for a second.
Sorry.
It's over here, but
I know, I'm sorry. She is much more experienced with, especially teaching it with patients. She's gonna know little tricks and tips that I don't. Cardiomyopathy, this is disease of the cardiac muscle. Okay. So this is a very broad term that describes any issue resulting from disease of the myocardium. If you have primary cardiomyopathy, this issue develops on its own. If you have secondary, it's caused by something else. So it is a comorbidity of another disease, of another underlying disease. Your risk factor, there's a lot of risk factors, but a positive family history. If you have a family history of cardiovascular disease, it definitely has a genetic component for sure. Also within nationalities too, or ethnicities. Ethnicity, that's the right word, right? Ethnicity, not nationality. Ethnicity. Thank you. I'm like, wait a second, that's not right. Complications from cardiomyopathy include heart failure, arrhythmias, and sudden cardiac death. Your signs and symptoms can be asymptomatic. You have to remember, our bodies are extremely resilient. We will fight with that negative feedback system all day, every second of the day, trying to remain homeostasis, right? We are always, every second of every day, achieving balance within our bodies. And someday, unfortunately, those compensation methods will fail. And that is when we become symptomatic. When you have someone where it's like, there was no symptoms, I don't understand. How did this person that runs 6 miles a week and he's healthy and he plays basketball on the weekends and he does this and that and he just cardiac arrested and died? How does this happen? Because that person's body was so good at compensating. And unfortunately, those compensation methods failed. And they failed in the worst way. Usually we become symptomatic in a progressive way, right? It starts small, it gets bigger and bigger and bigger. Sometimes it happens suddenly. Heart failure signs and symptoms, and then heart murmurs could also be symptoms. Diagnostic, an echocardiogram, it is easy. It's not invasive. This is not invasive. An echo is just an ultrasound through the chest wall. Now you could have what's called a TEE, which is a transesophageal echocardiogram, which means they put you in like a twilight sleep and they put an ultrasound down your esophagus to have a better look at your echo of your heart in the chambers. Sometimes when a patient has a lot of upper body I was gonna say fat. I didn't want to say fat, but even when a woman has a very large chest,
Well, yeah.
so I don't care if you're 110 pounds. If you have H-size breasts, they're getting in the way.
Yeah, that's a lot of adipose tissue.
That's a lot of adipose tissue. Yes, thank you. So if you have a large chest, male, female, whatever, or you are obese or whatever, that ultrasound through the chest wall might not show all of the things that they really want to see or as good visualization, which is when they have to do a transesophageal approach and go down the esophagus to get those pictures.
Because I hope I never have to get anything like it, because I would definitely have to get.
You would be a candidate?
Well, because my doctor's gonna say I'm too fat, like when she did my son.
You know what? I don't like your doctor.
She made me do it in two steps, like she wouldn't do it in the same day, because she said I was too large to do it all in one day. She made me do it in two steps.
I don't like her.
Yeah, so I know for sure I would be getting put to sleep and something going down my throat.
You also have a chest X-ray. What do we show on a chest X-ray when it comes to cardiac?
The size.
There's really only one thing: the size, cardiomegaly. That's really all you're going to see on a chest X-ray when it comes to the heart. You're only going to see the structure. And then a cardiac MRI, you see this when you're very much more specialized within your cardiac workup. They don't just do cardiac MRIs all willy-nilly. So you're definitely going to have an echo before you have that MRI. But you will need this if you're going to need any type of open heart or anything very much more invasive. And then other diagnostics, this is probably going to be the very first thing they do is an EKG or ECG monitoring. T, I'm losing you.
Yeah.
I'm losing you. Who else am I losing? Do we need to take a break?
No, it ain't.
I do have to pee, I will say that.
Yeah, I do like her. We'll take a breakdown.
How are we doing online? Do we need to get up and shake around a little bit?
That medication.
Yeah,
Yes, I would appreciate it.
That would be a great idea.
I agree. Let's do, we have what, 1 hour? One more hour? All right, let's do, come back at 2:35. Which,
Yeah.
hey,
At least you're vacated.
amen. Okay. So we are going to do the next slide, but then we're going to save the case study for Wednesday for Brandy. And after we do this next slide, we're going to go to hypertension, which I believe is slide 51.
So are we going to crisis points for decompensation? Or no?
This slide, hypertension. That's where we're going after this next slide.
Well, this one, the next slide, because you said we're gonna save the case studies.
Yeah, this next slide is
Oh, okay.
different types of cardiomyopathy.
That's because I've been moving ahead. That's okay. I got lost.
Huh?
Do I move ahead? Like, I have my own system over here, Jess. Hey, Jessie.
All right. Oh, yeah, I hate the name Jessica. Okay,
Where are you? You're so much with my kids.
we are talking about different types of cardiomyopathy. There are 3 types: dilated, hypertrophied, and restricted. Okay. Dilated cardiomyopathy is genetic. It can be caused by infection, alcoholism, or giving birth. It's characterized by large chambers that are relatively weak. The walls of the chambers are weak. You have impaired systolic contraction. So the atrial contraction just doesn't work as well. You have an extra S3 heart sound, and all of your valves are they're not working great. They're not great, especially the mitral valve. And it can put you at risk for AFib and ventricular tachycardias. I want you to look at this chart. I don't want you to spend, like an hour on it, but I do want you to know the different characteristics, like which one can be genetic, or which one, I definitely want you to know what hypertrophy means. That's important to me that you know what the hypertrophy means. Okay. So hypertrophy, this can also be genetic. This is asymmetric myocardial growth. So let's say the left side is growing bigger than the right side. Okay. And there's an overgrowth of the septum. The septum is what is in between the right and left side chambers. You have an extra S4, and your mitral valve is very affected. For restricted, this can be caused by infiltrative and storage diseases like endomyocardial disease. So endo meaning within, so within the heart. The inside of the walls are rigid, and the heart wall is resistant to filling. So there's like no stretch, right? You want your chambers of the heart to be able to stretch and fill and then contract to get the blood out, right? So with restriction, you have very rigid chambers. They don't want to relax and contract. You have impaired diastolic and systolic function. So your contraction and relaxation is compromised with restriction. Okay. What?
But you just said, I think you just said the opposite of what that says.
Impaired diastolic relaxation and normal. Oh, sorry, I did. I thought it said and systolic. That's my bad. I'm sorry. I hate when I do that. I see the look on her face and she's like, huh? I always know when I screw up because Tanisha is the one that catches it the most with her face. Okay, so impaired diastolic relaxation. So the filling of that chamber of the and that's when it relaxes, is when it fills, is impaired. You have extra S4. It affects your atrial ventricular valves. And it shows by low, this is referring to the conduction system, the electrical impulses. When it says low amplitude signals, you have small QRS signals, and you could have an atrioventricular block, which we're going to talk about Wednesday. Like I said, I don't need you to spend a lot of time on this. Okay. Okay. Hypertension. We're going to skip ahead. All right. Hypertension is a condition where the pressure in the blood vessels is consistently higher than normal. This happens in two ways. You either or you have increased peripheral resistance and or increased cardiac output. Vasoconstriction causes increased resistance, which causes increased blood pressure. Vasodilation is the opposite, causing decreased restriction and decreased blood pressure. I want you to know these terms. Increased peripheral resistance equals increased blood pressure caused by vasoconstriction. Okay. Your increased cardiac output is caused by an increased volume of fluid, which if there's too much volume, then there's definitely going to be an increase in pressure because it has to work harder to deal with the increased volume. Make sense? Hypertension, the silent strain on the system. And truly, hypertension is one of our key silent diseases. A lot of people don't realize that they're as hypertensive as they are until all of a sudden they don't feel well. They have this pounding headache. They go to the hospital because they're not doing well and they are 180 over 100. And it's like, how long have you been living this way? We have no way to know because we have no idea how long they've been hypertensive. Okay. So again, this is a condition where the pressure in blood vessel is consistently higher than normal. It's a function of increased peripheral resistance and or increased cardiac output. Why it matters is because chronic high pressure accelerates damage to the heart, brain, kidneys, and blood vessels. Okay. So our normal blood pressure is our 120 over 80, right? Pre-hypertension, I need you to know these numbers. Okay, these numbers are important. Pre-hypertension, 120 to 139 over 80 to 89. We have stage 1 hypertension is 140 to 159 to 90 over 99. And this is when it gets a little streaky here. When we get a little urgency, 160 over 100. Okay, we're getting a little sweaty. And now we're in hypertensive crisis with 180 over 120. Okay. So this is pretty much the same thing, just in a different way. I like that this shows the increased peripheral resistance. See how the constriction narrows the vessel, which causes an increased resistance. So I like that little picture. And then increased cardiac output is just an increase in volume. There's too much fluid. So what is the difference between urgency and crisis? This is important to know. Urgency, there is no target organ damage. Yeah, we need to do something about it, but you're not gonna like stroke out right this second and like shut your kidneys and everything down. Okay. Crisis is abrupt. It's acute, rapid. That's 3 different ways of saying it happens really fast and it's bad. Okay. So this is a rapid increase in blood pressure resulting in end stage organ damage. It's not all about the number, but how rapid it happens. So if all of a sudden you go into a hypertensive crisis and it happens within an hour, you could suffer severe damage over someone that has chronic hypertension that's been 170s over 100 for the last 5 months. Okay, see the difference? So for hypertensive crisis, it is extremely important that you lower the blood pressure slowly. I need you to know this. And you're probably going to have to do the math to tell me how much you need to decrease that blood pressure if it's by 10 to 20%. Okay? So, your symptoms include blurry vision, altered mental status, and sometimes seizures. So why do we need to lower it slowly? It's because our brains get accustomed to the high blood pressure, right? This is our compensation method. Our body is always trying to compensate because that's how it saves your life. So if you drop the blood pressure too quickly, it can cause perfusion issues like hypotension, even though it's still hypertensive, right? As organs are accustomed to perfusing at a higher pressure. So if your body has been accustomed to, yes, it happened abruptly. I understand that, okay? I'm not saying that it doesn't. But say you've spent a couple hours here, right? You've spent a couple hours at this 180 over 120. And you go into the hospital and all of a sudden they hit you with hydralazine and labetalol and drop you to 120 over 80. You're going to drop to the floor like a sack of potatoes. Okay? Because all of a sudden your brain just stopped oxygenating and your tissues and your organs are not oxygenating. Okay? So that's why it has to lower slowly. So the first hour you decrease by only 10 to 20%, and then there's another reduction of 5 to 15% in the next 24 hours. First hour, 10 to 20, the next 24 hours, 5 to 15%. So the risk factors for a hypertensive crisis include a poorly controlled hypertension, kidney failure, young African-American males. My cousin's husband, 37 years old, African-American, who knows how long he was so hypertensive when he had that heart attack and needed 3 stents. His dad actually passed in his 40s by uncontrolled hypertension and a massive MI.
Check all the boxes.
Genetics, ethnicity. I don't know what he eats. I don't know anything else about it. But I do know that these risk factors, especially those non-modifiable risk factors like genetics, that's hard to control. That's hard to beat. Just like me, I'm at risk for osteoporosis. I'm a young, or not really young, but a white female.
You are young.
I am, well, yeah, I'm young, but like that's not a characteristic of osteoporosis. I was saying like I'm more at risk than most, well, of us in this room.
Some of us.
Some of us. Half of us. So Again, your symptoms include blurry vision, sudden vision loss, altered mental status, seizures, encephalopathy. Your treatment, again, 10 to 20% in the first hour, 5 to 15% over the next 24 hours. IV metoprolol is going to be your first drug given. And this is going to, because we talked about it doesn't affect the blood pressure so significantly, but it helps with contractility and cardiac output, right? And we don't want to rapidly reduce the blood pressure. We want to reduce it slowly, which makes metoprolol kind of the best drug in the situation. If that is not sufficient enough, clevidipine, sorry. It's a calcium channel blocker. The other name for it is, I want to say it's Cleviprex. I don't remember. This is an IV medication. I feel like I'm wrong. I'm gonna stop talking. Is it Cleviprex?
Yeah.
Okay. It's a drip.
You're right, IV medication.
Isn't it a drip? It's an IV drip. It's a titrated drip. And it can only be given for a short period of time. I'm going to stop talking because I don't want to confuse anybody. Okay. But you have calcium channel blockers. Hydralazine is a very common PRN blood pressure medication. Nicardipine is also a calcium channel blocker. And then you have sodium nitroprusside, which is the last resort. Does anybody remember a very odd side effect of nitroprusside?
We talked about this.
We did talk about this drug. It's odd. It's very odd.
Blinky but late.
No.
We talked about it. Now I can't remember, but we definitely talked about this drug.
It causes something toxicity. Cyanide. Thank you. I kept thinking cyanosis, which is caused by cyanide. But nitroprusside, when it's metabolized, the byproducts can cause cyanide poisoning toxicity.
You were right about this clevidipine, whatever.
Oh, good.
All of the stuff you said was right.
Oh, see, my brain works sometimes.
Okay, so this might sound like a dumb. Class, when we were doing up there for hypertensive crisis, part of their first line was Lobeco.
It's a beta block.
That's
Yeah, I know they're all the same, but I'm saying it because
it's not all the same. So she's asking, they had a mock like situation with a hypertensive crisis, and their first line drug was labetalol, which is also a beta blocker. And you have to remember too that not all beta blockers are made the same, right? Alpha or beta 1 heart, beta 2 lungs, right? So some beta blockers are going to work differently than other beta blockers. Labetalol and hydralazine are going to be your absolute most common PRN antihypertensives.
I was gonna say, I know labetalol is safe in pregnancy, and that could be.
I believe most beta blockers are safe during pregnancy, and so is nicardipine, by the way. It's one of the only calcium channel blockers that's safe during pregnancy. And you work OB, right? Yeah,
And
so
they
that's
put me
probably
on
why.
labetalol because they didn't know if I could be pregnant. But labetalol doesn't work for me at all.
Funny tidbit. I know they're probably having a hard time following along right now because of our side conversations, but it is important. It's a very good to know because when you become a nurse, some of the most common medications that you are going to give at the bedside is labetalol and hydralazine. And what's funny and interesting, and I don't know why, I should look it up, but I really don't know why. I only know it because clinically of seeing patients is that one always works better than the other, and you never know which one it's going to be for each patient.
if there's this group for labetalol, hydralazine, and the labetalol isn't working.
Correct. So if the labetalol, so sometimes if you have a patient that you're treating for PRN hypertension and you give labetalol and it lowers their pressure a little bit, but it's not significant. Maybe they go from like 150s to 135 or something, but then you give them hydralazine and it drops them to like 110. You know what I mean? So and you never know which drug your patient is going to respond better to until you give it. Or unless they, know. So anyways, so this gives a little like snippy thing down here. A patient is admitted with angina and hypertensive crisis. On admission, the blood pressure is 240 over 120. The nurse recognizes which of the following is consistent with current blood pressure management strategies. Okay.
Where are you at?
I'm reading it from my own paper.
Okay, so read it one more time, Jen.
A patient is admitted with angina and hypertensive crisis. On admission, the blood pressure is 240 over 120. So we are in crisis, hypertensive crisis. The nurse recognizes which of the following is consistent with current blood pressure management strategies. A, in 2 hours, the target BP is 140 over 90. B, in 1 hour, the patient's target blood pressure should be 180 over 90. Lowering the blood pressure too quickly may lead to rebound hypertension. And D, the nurse should anticipate using oral medications for hypertensive crisis.
I think what was the big, because I don't know the math
Overnight?
on how to see how to get the 10 and 20%.
Yeah, that's what I'm confused about too.
What was the original number? 240 over 140.
The original number is 240 over 120. A says in 2 hours, the target blood pressure is 140 over 90. B says in 1 hour, the patient's blood pressure should be 180 over 90.
180 over 90. Sounds better.
So this is a very good example of a question.
48.
This is a very good example of a question you could see on your exam. So it would be in your best interest to know how to do the math to see what would be 10% to 20% of a decrease.
Yeah,
I know, right, so 10 is rebound. 10 is 0 off, and then. I'm gonna say rebound.
The answer is B, 180 over 90.
That's what I said.
I know this is right.
But how I don't know how I got the answer.
That's what I put in the chat.
The 140 was just what you get. Yeah.
Yeah, 140 was definitely too low, especially when we're only talking about a 10 to 20% decrease. So, yeah, so,
That's on the next page. How long is the next blood pressure be?
That was after 2 hours, but only. So the first one was 1 hour, the second one was 2 hours.
oh, it's on the next page.
But I guess I can keep your explanation.
So,
Like what? 182. I mean, not 182, 192. Because I had did the math for that, and that's why I was like, that's not 182. I was confused. Yeah.
so what is 10% of 120?
120 is what?
Okay, so what's 120 minus 12?
Already?
Okay, so, and then what is 20% of 120?
Before? I mean, 25 and 120? It's 20.
What is 120 minus 24?
96.
So your target diastolic range for this patient would be 96 to 108. I'm pulling out the camera. Let me show you.
The diastolic, all the things we're looking at when I.
No, that was just an example. I'm gonna show you, hold on. 240 over 120.
The diastolic.
Let me stop sharing over here. I lost my pen. Okay. So, your blood pressure is 240 over 120. So, we want the high and the low. So this is, no, I'm not gonna write it that way. I'm gonna write 10%, 20% of both. Okay.
I can't see the bottom part of what you're writing right now.
I'm gonna move the thingy. Sorry, thank you. Okay, so what is 10% of 240? 24. So 240 minus 24 is what? 216? Okay. And then what is 10% of 120? 12. 120 minus 12?
I wrote 108.
108? Yeah. So a 10% deduction of this blood pressure would give you a goal of 216 over 108. Now the range is 10 to 20%. So what is 20% of 240? 48. So 240 minus 48 is what? So our top number is 192. What is 20% of 120? Oh yeah, we already did that math. But I know, but I don't want to skip steps. I want to explain it thoroughly. So if 10% of 120 is 12, then 20% is going to be 24. So 120 minus 24 is going to equal 96. So the goal for this patient in the first hour is going to be a blood pressure of 216 over 108 to 192 over 96. Does that make sense? How do we all feel about that?
Is that what B was? I thought B was different numbers. I didn't. Yeah, that's what I'm
96.
Yeah, listen, she wrote these. I'm just showing you math.
Well, that's why.
That would have been the closest one. The 180 over 90 would have been the closest one.
Wouldn't that be? Yeah, close ain't cutting it with the heart now.
Let's say cutting it with the heart. All right, so let's make
Get the concept. If I knowing that number was wrong, that I get it.
I hear you.
I would have to do more math, but the only way I could think maybe is because it's after the hour and it could go down another 5 to, what is it, 15% or something after the first hour.
Yeah.
So maybe
the next
Yeah.
24 hours.
But I'm not going to,
Yeah.
first of all, I'm not going to ask you confusing questions where it's like, is it the first hour? Is it the third hour? Is it you know what I mean? Like it's either going to be within the first hour or it's going to be over the next 24 hours. That's what the question is going to be. Okay. So let's just say our other example, we have a patient that has a blood pressure of 208 over 124. That's what our patient walked in with. Okay. So let's do a 10%, a 20%. reduction. So what is 10% of 208? 20.8.
20.8, which will give 187.2.
Now, this is blood pressure we're talking about, and we don't use decimals in blood pressure. So we're going to round to the whole.
187.
And I am never going to ask you a question that is going to give you a decimal point where you are in between two answers by a decimal point. I will never do that to you. So we're going to go 187. And then what is 10% of 124? 111? What you said? Okay. So what is 20% of 208? Did you say 99?
It's gonna be 166.
166 over. 166.
166.
Oh,
Oh, I was like, what are you talking about 99? I didn't get there yet.
I didn't try to figure out how many I needed to track that was too much for my brain.
So what did you say, 166 over 100?
166 over.
Oh, I'm sorry, 99. So does that make sense how we're finding the 10% and 20% deduction in the first hour?
It does now. Yeah.
Everybody's good on that?
Yes.
Okay. I think it was just a poor question.
Yeah.
Yeah. So I'm glad. So are we glad we did this and worked it out?
Yes.
Yes.
Okay. Good. Any questions on how we got those answers? Because I'm glad to do it again or differently or whatever. Everybody good?
Good.
Okay. Okay. I love this camera. Math. I wish I could do stuff on the board, but my friends online won't be able to see it. So this is my next best thing, especially when it's right in front of you guys too, because you have it on your computers. Okay, we're good with that. So we are going into a case study. What day is the exam? Monday. It's Monday.
The following week it's Wednesday.
Yeah, besides the one place, we're not here on that Mondays.
Wait.
Week 2 is Monday, week 3 is Wednesday. Yeah. We will be. Still off. Every time I see it, they've been suggested on the light out. It's like being repeated as the ball.
Oh, it's because of the holiday.
Yeah.
Probably not. I'll do me this over.
All right. We gotta get through this case study. So let's focus. We only have 20 more minutes. That would only be if you printed the notes on the PowerPoint, because you're in PowerPoint. Yeah, because you downloaded the original file. Okay. I do really love case studies, but I also really need to get through more content because I need Wednesday to be heavy EKG stuff. Like I need to get through EKGs.
Mechanical heart failure today. It was 20 minutes that we have left.
Have time to finish. I mean, the case study is like 10 pages. And it's not that I don't love case studies. I really do. You guys know I love case studies. And there's another one at the end, I think.
Or maybe Instagram, or maybe we have that stuff. Sorry, we have for heart failure on Wednesday since it's not that much.
Yeah, it is small. All right. Yes to the case study or yes to moving on to mechanical heart valves and aneurysms?
Move on.
She said, move on.
Yeah, I agree. Move on.
You sure? Does
Positive.
We
anybody,
can circle back if we have time on Wednesday.
true,
But
does anyone want to veto moving on? Speak now or forever hold your peace. Oh, get out of here. I'm talking about mechanical failure. All right.
I'm thinking.
This is just such a yucky picture, but it's real. Like that's a real valve in a real heart. And I think that's kind of cool. So it does look terrible. But I still think it's cool. So I want you to know these words. Stenosis, that means hardening. The valve gate, so the open and close function of the valve is hardened. It can't open properly. And this obstructs forward blood flow, creating back pressure. If it's within the left side of the heart, that means it's going to be going back into the lungs. If it's in the right side of the heart, that means it's going to go back into the rest of the body, just like when we were talking about heart failure. Okay, same concept. Regurgitation is leaking. This is the valve gate cannot close properly. So it allows blood to flow backward. We never, ever want blood to flow backwards. That's never a good thing. Okay. So it flows back into the previous chamber. This results in less blood being pumped forward and poor perfusion, meaning poor oxygenation. Okay. So your key treatment is going to be a valve repair. You could have a balloon valvuloplasty or a complete valve replacement. Okay. If your patient has a valve replacement, if it is mechanical, what is something that they have to be on lifelong? Anticoagulants. What does your body like to do to foreign things?
Attack it.
Stick to it and clump on it and be like, you're not allowed to be here. Why are you here? Okay. If it's bacteria, we call that vegetation. If it's platelets, that's called blood clots. And this patient, especially with a mechanical valve, is going to be on anticoagulation for the rest of their life. Okay, because this is going to increase their risk for thrombosis. Okay. Aortic/mitral stenosis. So these are common valve disorders. The valve cannot properly open or close. There's less blood flow to the body due to it being stopped from flowing out, and the blood can regurgitate as well. So you can have stenosis and regurgitation simultaneously. Okay. Normally during systole, the heart contracts and the blood rushes through the aortic valve and it closes afterward to ensure the blood is perfused. So it pushes out, the valve closes so that the blood can't go back in, it goes out to the body. Okay. When you have stenosis, the blood cannot be pushed to the left ventricle or aorta properly, so it creates back pressure and sends it back into the lungs. This causes pulmonary hypertension. What vessel is more responsible for blood pressure, arteries or veins? Arteries. So if blood is backing up into the lungs, it's backing up into where and then where?
The pulmonary artery.
So remember, we said it was flipped.
Was going to the pulmonary vein, then the pulmonary artery.
So we said, tell me where it's backing up. Say that one more time.
So when the blood backs up from the left ventricle, it's going to go back into the lungs through the pulmonary vein. Okay. And then on the other end is the pulmonary arteries. So this blood being pushed back in to your lung circulation causes increased resistance in the vessels of the lungs. This is pulmonary hypertension.
And that comes from stenosis.
Having hypertension and having pulmonary hypertension are two completely different things. Okay? Pulmonary hypertension is caused by an increased pressure and resistance inside the vessels of the lungs itself. I don't want you thinking that they are the same. Does that make sense? Yes, Lisa, it can be caused by stenosis. There are other things that can cause pulmonary hypertension. Stenosis is definitely a big one. Stenosis and regurgitation. So this can lead to pulmonary hypertension, pulmonary edema, shortness of breath, dyspnea, poorly perfused extremities, and weakness. Okay. So then you have aortic/mitral regurgitation. This is where the blood flows back into the last place that it was. So for example, the left ventricle into the left aorta. Or I'm sorry. I saw A and I just thought atrium. The left ventricle to aorta. So the blood should stay in the aorta, but most of it flows back into the left ventricle. This is a long day. I've been talking for a very long time. Oh. So this happens because the valve doesn't properly stop that back blood flow. Remember, blood should never go backwards. Never, ever, ever. Okay? So less blood being pumped out of the heart creates back pressure on the lungs, which then also causes pulmonary hypertension, edema, shortness of breath, and all of those fun things. So stenosis and regurgitation really have the same signs and symptoms. Okay. For diagnosing valve disorders, you definitely want an echocardiogram. That's going to show you the actual functioning of the valves, the opening and closing, opening and closing. If you've ever seen an echo, if you ever get a chance to see an echo, I would love for you to see it. It has this blood flow where it shows you the red and it's red and blue, and it shows you when the blood gets pushed backwards, and it will actually show the regurgitation. Or if the valve isn't closing completely or opening completely, it will show you the valve function. It's very, very, very cool. Auscultation, sometimes you'll hear a murmur or a swishing sound. Clinical signs, again, you have fatigue, shortness of breath, weakness, and dizziness. You could do an exercise tolerance test. The patient would have to be healthy enough to exercise. Sometimes that's not the case. And then an x-ray to diagnose enlargement of the ventricles. This is not going to show you the valves. The only thing that's going to show you the valves is an echo, the ultrasound, or really just opening the patient up and looking at the valve. But to actually see the function of the valve in the least invasive way is going to be a regular echo. For treatment, you want to do either a valve repair, a balloon valvuloplasty, which is a small wire with a deflated balloon is inserted into the femoral vessel and it's guided to the valve that needs correction. You could replace the entire valve. And then if you have a mechanical valve, the patient can sometimes complain of actually hearing it tick, opening and closing. And when you auscultate, you can actually hear the mechanical valve moving, which kind of freaks me out.
Yeah, that was driving me crazy.
But I don't know, Grey's Anatomy episode where she's like, pig or cow, and then then she can't pick between the pig, the cow valve, or the mechanical. And then she's like, but I don't know if I can handle that. Anyways, so medications, you want to decrease the blood pressure with ACEs or ARBs, nitro to dilate the vessels to lower the blood pressure and increase perfusion. You can use beta blockers to slow the heart rate and reduce the workload. Anticoagulants, most definitely, especially if they have a mechanical valve replacement. And then antiarrhythmic to restore regular rhythm if the patient is having arrhythmias. And we're going to go over that a lot next week. Next, we have vascular emergencies. So this is the aorta. My husband has a mechanical valve. Whoa. So my husband has a mechanical valve and you can hear it if you're near him. That's wild. Does it sound like a clock, like a tick, tick, tick? Or does it sound different than that? That's so interesting. It does. It sounds like a clock.
Yeah, but I'm so used to it. I think all my kids are used to it too. I can't hear it unless I like force it or I'm at it.
Yeah. Okay, so this is your blood goes out through the left ventricle into your aortic arch. Okay, so the aorta goes down the body. You have a thoracic aorta, which is your chest, and then you have abdominal aorta, and this goes all the way down until it branches out into your legs. Okay, so you can have a thoracic aortic aneurysm, which is higher in the chest, or you can have a abdominal aortic aneurysm, which is what we call a AAA. This is one of the most devastating things that can happen to a human when it happens, when it ruptures and you never knew you had it. Okay. I worked with a lady, her husband, I think he was in his 40s or 50s. They were in their bedroom, they're talking, they had an ensuite bathroom. He comes out of the bathroom, he's standing in the doorway, and all of a sudden he grabs his chest and he says that he feels like there's someone literally stabbing him in his chest, collapses to the ground, and he was dead before the ambulance ever got there. And it was because his AAA ruptured and he never even knew that he had a AAA.
Many people don't survive.
It is the mortality rate of a TAA or a AAA rupture is extremely high. You would have to get there. You would basically have to already be at the hospital with a heart surgeon or vascular surgeon there, right there.
AAA, they did survive.
Not many of them
Their
survived.
quality of life was very poor, and then they died shortly after.
Yeah,
It's extremely high, exceeding 90 to 100%.
Yeah.
92% mortality rate. Yeah, it's
90 to 100%.
absolutely devastating.
They survived. They were on trains.
So, and actually, a lot of people that find out they have a AAA or a TAA, they find out like randomly. Like they went in for a chest x-ray or they had some type of abdominal ultrasound and they saw it on the x-ray because it was a structural difference, and it says, you know, you will come across patients that you'll see their images and it'll say under the impression, stable AAA, comparable to last year's image, 5x3x8. I'm just making up numbers, by the way. So you have different degrees of these TAAs or AAAs, okay? And when they're small and they aren't weakening the wall significantly, you can put a stent in the aorta. It can be a watch and wait situation, which is very scary if you ask me. But like I said, these rupturing are one of the most devastating things that can happen to a human. So 40% are in the thoracic aorta, 60% are abdominal. You have two types. The fusiform is a complete circumference of the whole artery. So it's on both sides symmetrically, okay? Saccular is when it only affects one side of the artery. So only one side of this artery is ballooned out, okay? So risk factors include Caucasian males, uncontrolled hypertension, smoking, hyperlipidemia, family history, a history of syphilis. I don't know why. I don't know that much about syphilis, to be honest with you. Symptoms, and this is the scariest part, is that it is asymptomatic until it ruptures. Now, with the abdominal, you can feel, especially when it does like advance, if someone has a large AAA, the patient or the practitioner can feel the pulsation through the abdomen. Okay. Now tonight, when you're laying in bed and you have your hand on your stomach and you feel your heart beating, please don't think you're gonna die, because I promise you, you're gonna feel it and you're gonna be like, oh my God, I feel it. I'm gonna die. Okay. There's normal, and then there's a bounding pulsation in the abdomen that is abnormal. Okay. I promise you, well, I can't promise you that you're not going to die of a AAA, but I don't think so. Okay. Thoracic, you have severe back pain, like someone is literally stabbing you with a knife in your back. Shortness of breath, hoarseness, and difficulty swallowing because it's up high and it just affects everything in the chest. And then this should say abdominal, not aortic. Pulsation in the abdomen and severe back pain. So that, and I'm telling you, I want you to remember that word, stabbing, severe back pain, okay, is characteristic of a dissecting aortic aneurysm. So treatment is blood pressure management because it can be caused by uncontrolled hypertension. And if you lower the resistance within the vessel, you might lower the chances of dissection. Acute IV medication management, and then chronic is a combination of beta blockers and calcium channel blockers. And this is truly just like a watch and wait, and hopefully maybe someday you'll get a stent. I don't know. So nursing interventions is going to be blood pressure control. We can't make them stop smoking, but we can try to teach them. Follow-up CTs for size management. So if you have a AAA or a TA, you're going in every year or 6 months or whatever to see imaging to make sure it's not getting any bigger. And then surgical interventions, hopefully before dissection. That would include a very large stent in the aorta. We're out of time.
So you can't just remove it.
No, it's the biggest vessel in your body.
A piece of it, because I mean, if it ruptures and you live, you're not gonna have it intact.
The only way.
That's what I'm thinking of. Because I'm thinking if it ruptures and you survive, you're still. But
Well, that was just our plan. That's just it.
so the vessel is still gonna be missing. I don't know. Maybe I'm thinking too much of it. Definitely.
I don't know. Any questions, guys, online before you go?
I have a question, but it's not about this. It's about the schedule.
Oh, okay.
For the
ahead.
19th, are we having a class and an exam or? Cause it's on my schedule, but it's like white out. It don't say like what time, but it says on Wednesday it will be exam too.
Wait, isn't the 19th Martin Luther King
Yeah, is
Day?
that day like? Do we not have?
That's a Monday. We don't have school
Okay,
that
because they
Monday.
put something there, but they just didn't put no times or nothing there. They just says exam and lecture online, but it's nothing Monday.
On the
Yes.
19th,
Okay.
no. That's why our exam schedule is messed up. Because our first exam should be on Wednesday, but it can't be on Wednesday because we don't have class on Monday. That's why our first exam is on Monday, which sucks. No, they're supposed to be on Wednesday, but we have the holiday, so it is what it is, but
So our first
it just
exam
sucks when
is
you only have a
Wednesday?
4-week term.
Correct.
No, our first exam is, hold on. Our first exam is Monday, the 12th. So we only have one more lecture day, which kills me. I hate that. I hate that so much.
Okay, thank you.
You're welcome. It's not the answer I wanted. Any other questions, guys?
A lot of information.
It was a very long day. Yeah, the one after that, Tiffany, the
Second exam
second
is the
exam
Wednesday.
is on a Wednesday.
Okay, that's what I was
Oh,
thinking
yeah,
about, not
just
the first one. I'm confusing myself.
Thank you so much.
sign out,
We'll do that.
please. Yeah, so the first exam is on the 12th at 9:30, and the second exam is on the 21st.
You guys find out.
So Canton Group A, you guys have clinical tomorrow, right? You know that? Ladies, I'm talking to you. Canton Group A, which is Mariah, Jackie, Tanasia, Ginger, Kiera, Rashonda, you all have clinical tomorrow. I said Rashonda. Who? Just said, what are you talking about? Who else has clinical tomorrow? Illyria?
Okay, so what time is that? I don't have a schedule. So what time? I'm sorry.
Well, Rashonda, I wanted to ask you about that. You two, do you want to do group A or group B? Group A has clinical on Tuesday, Thursday, and group B has clinical Thursday, Friday.
I can do group A, but well, no, let's do
Okay.
group B Thursday, Friday. I'm sorry.
Are you
'Cause that's what I
100%
was.
sure? Because once I change it, I'm not going to change it back.
Yeah, I'm 100% sure because I was thinking we were going by the old one. So yeah, let's do Thursday, Friday.
Okay, so you want to be group B. All right. Any other questions, guys? And Rashonda, I'll send you your schedule.
Okay, thank you.
Okay. Thank you. Have a good day, Jesse.
You too. Bye.